Good evening, all. On behalf of the organizing team, I welcome you all to the day 2 of ISCO International Conference on Tobacco Control and Smoking Cessation. I assure you all a very informative sessions ahead. The tobacco epidemic is one of the biggest public health threats globally, killing over 7 million people a year. Research critical to addressing this public health problem has leveraged variability in tobacco use, product market, and policies across different countries, settings, and populations, particularly in low and middle income countries, where tobacco burden is increasing. So there is dire need for better understanding of tobacco use and its impact, and tobacco control policies and industry strategies, especially in low income countries that are dealing with high tobacco burden. So moving towards our first session for today, it is my honor to introduce to you our special guest, Professor K. Srinath Reddy, President, Public Health Foundation of India, and former head of Department of Cardiology, All India Institutes of Medical Sciences, New Delhi. Although Professor Reddy's contributions to society in the field of public health and tobacco control and his achievements can't be summarized in few lines, but I would like to highlight some of his career distinctions. Under his leadership, Public Health Foundation of India has established 5 Indian institutes of public health in different regions of India to advance multidisciplinary public health education, research, health technologies, and implementation support for strengthening health systems. He was appointed as the first Bernal Lone visiting professor of cardiovascular health at the Harvard School of Public Health in 2009 to 13, and presently serves as an adjunct professor of epidemiology at Harvard. His contributions to public health have been recognized through several awards and honors, including WHO Director General's Award for Outstanding Global Leadership in Tobacco Control, Queen Elizabeth Medal, Luther Medal by American Cancer Society, and he was conferred Padma Bhushan Award by the President of India in 2005. He holds advisory positions in several national and international bodies and recently published a book, Make Health in India, Reaching a Billion Plus. He is also an adjunct professor of the Rolling School of Public Health, Emory University, and honorary professor of medicine at the University of Sydney. He is first Indian to be elected as foreign associate member to the National Academy of Medicine, USA, and was awarded several prestigious international and national doctorates and fellowships. Professor Reddy is also member of the Government of India Technical Task Force for COVID-19, and he is also advisor to the governments of Odisha, Andhra Pradesh, Haryana, and Punjab on public health. He held position of President, World Heart Federation from 2013 to 15, and co-chair Health Thematic Group, UN Sustainable Development Solutions Network. Today, Professor K.S. Reddy has obliged us by agreeing to share his views and experiences on a very interesting topic, that is closing the gap tobacco research in high burden, low income countries. And with great pleasure, I invite Professor K. Srinath Reddy for this session. Welcome, sir. Over to you. Sir, your mic is mute.
Thank you very much for this very kind introduction and for this very gracious invitation to be part of this conference, which holds tremendous importance for tobacco control, not only in India, but globally. Both because India is one of the major contributors to the tobacco-related disease burdens across the world, but also because India has been and should continue to be a leader in the global tobacco control movement. The topic that has been assigned to me is how do we close the gap in research for tobacco control between low and middle income countries and the other countries. Actually, the topic says, how do we close the gap for tobacco control? So is it that we are really trying to close the gap in the tobacco-related burdens, or the production and use of research in the area of tobacco control, where there are considerable gaps between countries? Or are we also trying to look at the closing the gap for the capacity that exists conducting relevant research in tobacco control? Obviously, these are all interrelated, because unless we build that capacity and nurture it well, we are not going to be able to produce the kind of quality research that can impact upon policies and programs and move us towards more effective tobacco control and thereby reduce the tobacco-related burdens. So I will attempt to try and deal with this broader theme. Indeed, recognizing that this conference has had a very rich scientific program with several experts of eminence who have already covered a number of specific topics in the area of tobacco control, and others would also be doing so in the latter part of the program. I will not really try and attempt some of the very specific issues related to tobacco control, nor even the epidemiology of tobacco burdens. What I will do instead is have a freewheeling presentation in which I will be talking about some of the broader issues and how best we should really advance research to greater impact and effect. In terms of the pandemic itself of tobacco, it is continuing across the world. There have been several successes at global, national, and even at the level of some of the sub-regional locations within India. We have seen a number of guidelines coming in after the famous Framework Convention on Tobacco Control, and we have seen several forms of action plans that have been adopted by different countries. We have seen monitoring mechanisms emerge, and we have seen also several successes in recorded declines in tobacco consumption in some of the countries. But the battle is inconclusive, and in many countries, the war is still not yet won. Some of the areas of weakness and vulnerability persist across the world in virtually every country, some more than others. At the same time, many new threats have emerged. We see several weaknesses. The non-initiation of tobacco control policies in some countries. Some have not even signed up to the FCTC as yet. Others who have are half-hearted in terms of their introduction of policies and programs with partial packages of measures and with very ineffective implementation of those measures as well. We also see that we are challenged by a diversity of tobacco products, making regulation difficult. While the title of this conference has smoking in it, I know that the scientific program has addressed other forms of tobacco, including smokeless tobacco. But whether smoked products or smokeless products, we know that there is such a diversity in many of the countries, including India, that has made regulation and even effective communication of the harm of tobacco fairly difficult in terms of advancing the tobacco control communication and strategies. In terms of the threats, the tobacco industry continues to pose the biggest threat. It continues to deny and distort evidence. It works hard to delay, dilute, and derail control measures. And at the same time, it is springing upon us a variety of new products, including the electronic nicotine delivery devices, be they e-cigarettes or the heat-not-burn products. Just as the COVID-19 virus is coming up with a number of variants, the tobacco industry also very assiduously tries to bring about new forms to challenge our regulatory authorities and also try and entice and entrap new customers into addictive practices, which can be very harmful and hazardous. We also recognize that our attention in policymakers and even in terms of public attention is being diverted by a number of other challenges, which do need to command attention at this point in time, like the COVID pandemic and climate change. We also recognize that wars, violence, and economic slowdown are continuing challenges to humanity, and where tobacco control advocacy sometimes gets drowned in the noise and the sound and fury of other campaigns that are addressing some of these major challenges to humanity. But what we really recognize is that some of these new products are also sadly splitting the public health movement. Some of the people believing that some of these products like e-cigarettes and heat not burn are likely to be helpful in terms of reducing the harm or promoting cessation, neither of which really have any evidence, but unfortunately, it does split the public health movement and confuse the public, and that is where research becomes even more important. We are also seeing new channels of communication emerge, the internet, the social media, which is being used very much by the industry and its supporters, but it is also necessary that those of us in the tobacco control movement who would like to engage both policymakers and the public in terms of ensuring that tobacco control stays on the agenda and advances into action, also learn to understand these media and employ them effectively. So that too requires research. There is a slackening of political will and public support, which is a danger that can undo or diminish the gains of the tobacco control movement because of multiple forces that I've already mentioned. Therefore, what we really require is continued research, which has to help us in overcoming these challenges. In terms of the context in which we are operating and where we have to conduct this research, we have to really position tobacco control in the broader context of Sustainable Development Goals. It is indeed now positioned after the neglect in the Millennium Development Goals, but we cannot allow it to be a mere mention. We have to make sure that tobacco control, which is very relevant to the other health goals, as well as the other development goals, is recognized to be an integral part of sustainable development in multiple dimensions, and that is where research must advance us into more effective action and advocacy. Non-communicable diseases have emerged as very important global priority, both with the 25 by 25 slogan given by the UN Political Declaration of 2011, as well as 1/3 by 30, that is 1/3 reduction in premature mortality due to non-communicable diseases in the age group of 30 to 70 by year 2030, which is now part of the SDG targets. And tobacco we recognize is a major risk factor for NCDs, and that is an argument that we must continue to advance. Not only is it a risk factor by itself, it aggravates and escalates the risk posed by other risk factors, be it hypertension or diabetes. And we must ensure that tobacco stays in the picture whenever any guidelines are issued, and this additional risk posed by the tobacco habit must be recognized by people who are addressing other risk factors as well in a composite risk profiling. We also recognize that if we are really going to be achieving the 25 by 25 target or 1/3 by 30 target, we have to really have impactful measures which reduce mortality in a relatively short time frame, which means that much of our effort also has to focus on secondary prevention of people who have already acquired the disease or likely to have a high risk of death if they do not stop the tobacco habit. And that is where we must ensure that tobacco becomes a very important part of the secondary prevention, and tobacco cessation becomes a very important element as well. While it is absolutely important to prevent the primary uptake of tobacco in the first place, particularly by young people and others who have never experimented with tobacco before, unless we ensure that tobacco cessation succeeds, we will not be able to have the impact on premature mortality that is demanded of us by 2025 and 2030. And that is where we must impress upon our policymakers that it's not merely the question of campaigning to prevent the uptake of tobacco, whether it's the older forms or the new forms, but also tobacco cessation in a very active manner. We must promote the research on cessation, therefore, that unfortunately so far has come mostly from high-income countries and that focus mostly on smoking. But we must recognize that we must produce more evidence on smoking, certainly, but the various forms of smoking, but also on smokeless tobacco, and see how we can actually develop adequate evidence-based interventions for promoting effective and early cessation. In low and middle income countries, the research on tobacco cessation needs to advance along with the prevention of primary uptake. Now, that brings us to the purpose of research. Now, research has to be understood as a very important instrument for policy and practice. And unless that is clearly distilled into the policymakers who are making the financial allocations, we will not see the kind of research that we need to see. The purpose of research is to generate evidence-informed, context-relevant, resource-optimizing, culturally compatible, and equity-promoting recommendations for policy and practice, which means that we require multidisciplinary research. Even when we talk about wanting to influence policy through research, enlightened policy, even by well-meaning policymakers, whether they are techno-bureaucrats or civil servants or politicians, will require of us several things, not merely the scientific evidence, but there are several other elements that are demanded of us. So enlightened policy requires scientific credibility, which comes from biological, epidemiological, clinical, and public health research. So apart from scientific credibility, we need financial feasibility, which comes from health economics, agricultural economics, labor economics, and environmental economics. And we also require operational stability. That means we require implementation research or health systems research, and also implementation in other sectors. We also require political viability. Who are the forces opposing us? Who are the forces supporting us? Is there a ready and receptive constituency among the policymakers, among the public, among the media? This requires social sciences research. So if we want to really bring to the table scientific credibility, financial feasibility, operational stability, and political viability, we have to have multidisciplinary research. And that is absolutely important if we want to initiate multi-sectoral action. Further, we must also learn to differentiate between evidence for policy and evidence on policy. Quite often, the purists have demanded that we must have randomized controlled trials for everything to show the benefit. While they are very useful, certainly, and particularly in the clinical arena, it is not always possible in the policy arena, and particularly in terms of population-based interventions, or where there are multi-component interventions that are required as a package, as in tobacco control, to develop that kind of evidence a priori from the randomized control trials. What you need is a multiplicity of data from different sources which can contribute complementary data to generate the evidence for policy. And then when the policy is being implemented, then we go ahead and identify through rigorous research how the policy has worked or not, that is evidence on policy. We have seen this happen in COVID-19. Masks were earlier rejected in 2020 on the ground that there were no randomized controlled trials, ignoring the experiential wisdom of mask use in Southeast Asian countries, or even the aerosol dynamics that came in from multiple sources, including from researchers in secondhand smoke. Now we recognize that masks are absolutely important. So while we are pursuing research, we must recognize the various types of research and what use they can be put to. Then in terms of research priorities, what are the research needs which need to be addressed? We recognize that there is a changing profile of tobacco products and nicotine delivery devices. There are changing demographics and epidemiology. We need to understand and track the patterns of beliefs and behaviors across different population groups. both with respect to the potential to prevent primary uptake and to promote cessation. We need research in tobacco economics, the environmental impact of tobacco, the social impact of tobacco in terms of aggravating poverty, depriving families of education and nutrition. We need the economic impact of tobacco, and all of this is going to be important. And of course, we need to do a research on the influence of the industry, which continues to corrode policy. And that is where the nature of policy responses to tobacco control becomes an important area for research. We need research on the impact of tobacco control programs as well, the program evaluation component, and also to see which components are working well and which are not, and which combination works best. We need research on health system commitments and performance. We need research on policy coherence, but at the same time, multi-sectoral coordination for implementation, action. We need research on tobacco industry tactics. We need research related to advocacy and health literacy, what works, what doesn't, in terms of impactful advocacy and effective communication to the public. In terms of policy research, of course, there are a number of areas like strengthening the COTPA amendment, tobacco industry interference, taxation policies, regulation of advertising and promotion, including the point of sale advertising. All of these feature very much here in India, but also the whole area of surrogate advertising and infiltration into the social media. All of these become important areas for research we must continue to pursue. At the level of epidemiology, whether it is population epidemiology or molecular epidemiology or microbial epidemiology, we must look at new areas. How do we bring in big data and have data linkage? How do we look at the epigenetic effects of tobacco consumption? How do we look at the effect of tobacco consumption on the microbiome and on inflammation, which is widespread and which can be one of the mechanisms by which oral or even smoked tobacco can distort the microbiome and thereby cause multiple diseases, whether it is cardiovascular disease or diabetes and cancer, of course. We must strengthen surveillance systems. And how do we do that? That again requires research. In the area of economics, we must look at the price of inaction. What are the consequences, the economic costs of not having effective tobacco control? And what is the price of action? What are the economic benefits of effective tobacco control? We must look at illicit trade, the practices, and how are the control measures succeeding. We must look at tobacco-related employment and look at alternate modes of employment and what can be generated fast and effectively so that the argument that the tobacco industry frequently uses against tobacco control can be defeated. We need in social sciences assessing inequalities in the tobacco consumption habit as well as the impact on families. We need to look at inequalities at the individual and the area level. We need to look at the impact of tobacco use on education, effect of different health promotion strategies for tobacco control. All of this requires social sciences research. And implementation research, we must see how the Empower package is being implemented as a whole and the individual components. We must look at health systems. Integration into primary care becomes very, very pivotal. The 15th Finance Commission has now said primary care financial allocations will be going to the local bodies, the panchayats and the municipal corporations. Now in primary care, how are these resources going to be utilized by the panchayats and the municipalities for health promotion and tobacco control, including cessation? Can we actually work out methods by which we can see how best some of these agents of action at the local bodies can be brought in as champions of tobacco control? And what is the research that they require to convince them? And what is the research we need to do to show how best we can influence them? Therefore, in the whole area of health systems and primary care, we do need to penetrate much more in terms of our research, action, and efficacy. We need to look at how the National Multi-Sectoral Action Plan is functioning and how we are positioning tobacco control in other health programs as well. We need to do research in developing effective community-level decision-making and community-level support systems. We need also to look at how best we can support cessation services, both through individual-based, clinic-based, and community-based interventions. But for all of these, we require capacity building. And therefore, we require multidisciplinary research, which is both acting at the level of the engagement of medical professionals, public health professionals, professionals in the area of economics, social sciences, and other development sectors. And we therefore need to bring in people who have a depth of research in one dimension, but have also the ability to connect with other disciplines and look at how collaborative research can be done across disciplines. So we need to create those T-shaped individuals as researchers. We need dedicated programs for research methodology skills being built up. So we need a variety of quantitative and qualitative research methodology skills being built up. And particularly, as I said, because we require evidence for policy, which has to come in from multiple streams of knowledge, we need to see how we can integrate all of those disciplines. We need a mentor-mentee relationship for developing young researchers. We need earmarking of funds to support context-relevant research in India on the basis of prioritized research agenda. We need to explore new technologies to scale up research, artificial intelligence, as well as digital technologies in an appropriate manner. We need to develop mechanisms to authenticate the veracity of research when the tobacco industry continues to pollute research and influence policy with all kinds of spurious research, sponsored research. We need to identify through our own research what are the loopholes in that research, what are the fallacies in that research, and continue to expose them and continue to expose the vested interests who are collaborating with the tobacco industry. So all of that requires a very strong research capacity on our side, not merely shrill advocacy. We need tobacco control in the context of sustainable development. We need to ensure that tobacco control features in almost every element of sustainable development, whether it is poverty reduction or reshaping the agricultural systems to free up agricultural land from tobacco for nutrient crops, or when we look at the effect of tobacco on education or on gender. All of these, everywhere we ought to bring in, wherever relevant, tobacco control fairly strongly into the picture. But we also need to communicate our research much more effectively, with conviction, with clarity, and with confidence. So our researchers in tobacco need to be trained in this as well, particularly the younger researchers. How do we do that? So that they become active agents of change, bringing scientific credibility, but also a conviction and clarity in their communication to policymakers and the public. And therefore, we do require also multiple opportunities for collaborative research within India, as well as international collaborations to build that huge critical mass of continuing research commitment. At the same time, we also need to ensure that there is research addressing the new forms of tobacco. And there, even more effective communication is needed to counter, because there's a lot of confusion on these e-cigarettes and heat and burn cigarettes. We must do research on how best to use our new media. Also, advocacy research is also a very important element. If science is the blood circulation that carries information to policymakers, advocacy is the oxygen that activates an energetic policy response from them. So we need research on how effective advocacy can be carried out as well, in partnerships with others, in coalitions with others with convergent interests, with environmental groups, with the food security groups, with the poverty alleviation groups, and a number of others where we can bring tobacco onto the table. We identify with their causes, they identify with our causes, because there are common concerns, but that research endeavor must translate into an effective collaborative advocacy. I would like to conclude by saying that the Public Health Foundation of India and the Indian Institutes of Public Health will be happy to assist in this endeavor of building up research capacity and building up that kind of a critical mass of research across the country. I know that the overall slogan, the theme of the conference is knowledge to action. I would urge you by saying that knowledge to action is very important, but action must translate to impact, and impact must translate to equity. And that whole channel of translation of knowledge to action, which is impactful and results in equity, is best illustrated by how we pursue the agenda of tobacco control in the framework of sustainable development. Thank you very much.
Thank you, sir. Thank you for this informative talk, including the details on challenges and hardships in the path of tobacco control movements. And also you have very clearly covered the importance of researches and dire need of tobacco cessation and how we can achieve it by involving everyone in this. And it was really a very informative talk and very inspiring talk. And on behalf of all the organizing team, I thank you for sparing time for us and enlightening us with your thoughts and experiences. Thank you, sir.
Thank you very much.
Now, moving further, I request Deepak Seni to carry forward this conference to the next session. Over to you, Deepak Seni.
Dr. Richa, now I would like to invite Chairperson of Session 5, Dr. Sushmita Pathy. Dr. Sushmita Pathy is Professor, Department of Radiation Oncology, All India Institute of Medical Science, Delhi, India. And Dr. A.C. Kataki. Dr. A.C. Kataki is Director, B. Barua Cancer Institute, Guwahati, Assam, India. I request to the Chairperson to kindly proceed the session.
Hello. Hello, can you hear us?
Yes, sir, you are audible.
Okay. At the very outset, we thank the organizers for giving us an opportunity to participate in this international conference on tobacco control and then smoking cessation. I, on behalf of the co-chairperson, Professor Sushmita Pathy from All India Institute of Medical Sciences, New Delhi, take the pleasure to invite Dr. Navjit Singh, Additional Professor, Department of Pulmonary Medicine and Sleep Disorder from the PGI Chandigarh, to speak on the lung diseases and chronic obstructive pulmonary diseases.
Good evening. Welcome you all for the session.
Thank you, chairpersons. And at the outset, I'd like to thank Dr. Abhishek and all the other members of the organizing committee for inviting me. And in the next 10 minutes or so, I will be talking about tobacco cessation in the context of lung diseases and COPD. So this is my disclosure slide. And I'll actually start in a reverse way, the summary. So the common question or the myth which a lot of people might have is, what are the known benefits of tobacco consumption? And the simple answer is there are no known benefits of tobacco consumption in any form. Another important question or a myth is still, what time point is it useful to quit tobacco consumption? And the simple answer again is, it is never too late to quit tobacco consumption. And so with these words, I'll actually go into the details. Now, this was a paper published in Lancet in 2013, which shows the differences in all-cause mortality between smokers and non-smokers, smokers in blue and non-smokers in red. Now, as you can see that there is approximately a threefold difference in annual death rates on mortality. And this difference keeps on increasing as the age increases from 35 years to 80 years. As you can see, at 60 years, this difference is small, goes on increasing at 70 and even more at 80 years. Now, if you go into more detail about this, you can see that if you look at the mean age of stopping and the relative risk, this is approximately 1.6 or the all-cause mortality for smokers compared to never smokers. And this has increased with the age at stopping smoking. But just look at this, the relative risk for lung cancer. It starts at the risk for which there is overall mortality risk and keeps on increasing to approximately 5.9. Now, if you go into more details, there is no denying the fact that chronic lung diseases and cancer of the lung are the two most important problems for mortality in the context of tobacco smoking. As you can see here, relative risk of 35 and 24. This is far, far higher and of a much bigger magnitude than any of the other diseases which one can see. And again, so there is clear evidence that smoking kills. So if you look at the number of cigarettes per day and the relative risk, it is very high for chronic lung diseases, predominantly COPD, to the order of 60. Similarly, lung cancer, order of 36, as opposed to coronary artery disease, which is in the range of approximately 6, and for cerebral vascular disease, order of 3.8. And so these are basically 12-year relative risks for current smoker versus never smokers by the amount smoked. Now, even if you take the latest data from the Global Burden of Disease Study 2019, and you look at the proportion of all-cause deaths attributable to smoking tobacco use among females and amongst males, there are some very clear insights which one can get. So on the left are the deaths from cancers and chronic lung diseases, and on the right are from all other causes. And as you can see, cancers and COPD for males, the number of deaths attributable are very high. And even once you quit smoking, this risk remains for at least 20 years or so. Now, this is of a much lesser magnitude for females. And on the right, you can see are the similar graphs for all other diseases except cancers and COPD. And you can see that these are almost matching, which again indicates that cancers and chronic obstructive lung disease are a very important component of the effects or the ill effects of tobacco smoking. Fortunately, once you quit, the cardiovascular and pulmonary benefits are almost immediate, but the cancer risk lowering takes a few years. However, reducing cigarettes is not enough. There has to be nicotine compensation in some form for most people, and there has to be a stable non-daily pattern in order to help achieve these benefits of quitting. Now, everybody is aware of this, and I'm sure this has been discussed multiple times and will be discussed today also, the 5 A's for tobacco cessation. And it revolves around asking about tobacco use, identifying and documenting tobacco status for every patient, advising them to quit at every possible interaction, assessing the willingness to quit, assessing in the quit attempt, and that is by providing counseling and pharmacotherapy, and arranging follow-ups to achieve these goals. And now just a diagrammatic representation of all of this. So as you can see, this represents the assessing the willingness to quit. And on the right are the pharmacological methods. These are nicotine replacement therapies in its various forms, and other pharmacological attempts like varenicline and bupropion. There has been a lot of talk about using e-cigarettes as an alternative to tobacco smoking, and possibly that they are less harmful. But now there are enough papers in the last 2 years in Lancet and NEJM that these are not as safe as they were believed to be, and you have had hospitalizations, deaths, pulmonary illnesses from these things, and this is not something which we should be advocating as a healthy substitute to tobacco quitting. And this paper was led by Dr. Ravi Mehrotra, whom we all know, and this is basically about smokeless tobacco control also needing to be having our focus. The problem is that a very small proportion of smokeless tobacco users are advised to quit the use of smokeless tobacco products compared to tobacco users. And this is actually becoming a very big cause of concern, because tobacco, as I said, is harmful in all of its forms. Now, if you talk specifically of tobacco cessation for cancer patients, over the last 10 years, several algorithms have been defined which can sort of customize these 5 A's in the context of cancer care. And so as you can see, one of these algorithms shows how cancer-related distress is simultaneously incorporated while assessing the 5 A's. And this has been published in the Journal of the National Cancer Comprehensive Cancer Network almost 5 years back. Again, this is another from that paper, which you can see that the pharmacological management, there's a stepwise way of going about it. And a lot of things in that paper also describe how one can integrate cancer control or the active cancer treatment along with the 5 A's. And I would recommend this to be read by anybody who's interested in this field. And I'd like to wind up early and say that we have now moved from an era of having physical meetings in which everybody used to be in a single room and a PowerPoint display on the screen, and that is how it used to work. With the advent of the COVID-19 pandemic, for good or for bad, I cannot say, but we have now moved to this era where the speaker may be at one place, the attendees may be at another place, and people asking questions could be in a separate place altogether. However, we have to utilize this technology which has come about, use the social media to help people quit tobacco and help enhance the awareness of tobacco cessation as is being done by this conference. And with that, I'd like to thank you for the patient hearing.
Thank you very much, Dr. Singh, for the lucid presentation on effects of tobacco smoking and association with lung diseases. Now, the important fact I was wondering is something about the environmental, tobacco smoke, which we are all aware of, which is there both in the environment, maybe at home, maybe the public, which is very strongly linked with a lot of allergy and a lot of asthmatic diseases for children and for adults, and also for the senior citizens. And your talk regarding the ways to quit tobacco and the various scientific details that you have provided are definitely helpful for our viewers. And can we now a question, or shall I move on to the next speaker, my co-chair, Dr. Amal Kartiki? Shall we move on to the next speaker?
Yeah, Professor Sushmita, we can move on to the next speaker, but then before that, I'd like to use this platform to make an appeal to the Ministry of Health and Family Welfare, Government of India, to set up more regional tobacco quitline centers in the country. Now that we have only 4 centers in the country, which are regional tobacco quitline center. At the same time, I also request the Ministry of Health and Family Welfare, Government of India, to establish more tobacco cessation clinic in the different parts of the country, and then which should be linked with community health centers and the primary health centers in the country. Otherwise, there are many who would like to quit, but then they don't have access for counseling and then support.
Absolutely. So with this, it's my pleasure to invite our next speaker, Dr. Rakesh Yadav, who is a professor in cardiology at AIIMS, New Delhi. Over to you, Dr. Yadav.
Thank you, Dr. Susmita, for giving me this opportunity. And my task, I think Dr. Navreet has highlighted enough and given enough data of association of tobacco with various diseases. But my topic will be, in a heart patient, how to encourage smoking cessation. My conflict of interest was none. And we all know that tobacco use remains the most important preventable cause of early mortality and morbidity. And it's a major cause of cardiovascular disease. Quitting tobacco, especially smoking, rapidly reduce the risk of cardiovascular events in patients with or without heart disease. That is very important quote. The history of tobacco starts from 6000 before Christ. And usually in initial days, 86 to 161 AD, it was being smoked in the district of Tabasco, Mexico, as a religious ceremony. It first came in Europe in 1492, then Germany to 1556, and in 1600 it became a major cash crop of American colonies. And so, quote, no society that have adopted tobacco has ever given it up. However, the campaign against tobacco started in early 16th century when King James I of England in 1604 published a pamphlet condemning tobacco. In Russia, it started in 1700, but in 17th century, its use increases in Europe, and it has transferred mainly in 20th century as in cigarette smoking, which has more advantage as being claimed. However, the ban started in early 20th century that in 1925, America banned 14 states banned tobacco. In 1938, studies linked cigarette with lung cancer, and as early as in 1954, the smoking is related to cardiovascular diseases. We all know the nicotine forms, but we all know that the cigarette smoking is the most important culprit as far as cardiovascular disease is concerned. Smoking is the quickest and most efficient way to get nicotine in the brain, and its half-life remains 2 hours. That's very, very important because these patients require frequent bout of smoking because its half-life is about 2 hours. The one important thing I just want to highlight that nicotine is agonist for dose-dependent action on nicotine acetylcholine receptor, but in high dosage, it is antagonist. This is not only nicotine in cigarette, which is important for cardiovascular disease. This is a lot of other things like monoxide, tar, and we all believe that there are 4,000 substances in a cigarette which are harmful for the body. And in this 38 are important for cardiovascular disease. And these are the acute center effect. Why it is important? Because they are all related with cardiovascular disease. A patient of heart failure, patient of unstable angina, if he smokes, it causes more excitation, central excitation. Though this is believed that acutely it improves mental performance, improve motor steadiness, stress reduction, reward. And as far as its peripheral effect is concerned, it's a sympathetomimetic, so may lead to the release of epinephrine and norepinephrine. Both are toxic for the heart, increase heart rate, blood pressure, and parasympathetic stimulation also in GI tract, increase HCl production, chronic diarrhea. These all can be because of acute tobacco intoxication. This is again an acute effect. And mind you, this two important effect is very, very important. When it causes arousal, it increases the heart and blood pressure, which sometimes in a heart patient may be harmful. Carbon monoxide, which is present in smoked form, and it is the last 1/3 of the cigarette which contains 50% of the carbon monoxide or tar, reduces oxygen transport. So effective oxygen reaching to the heart decreases. It causes vasoconstriction. So these all may lead to adverse cardiovascular effect in acute setting. I hate these pictures always promoted by somebody when the tobacco is discussed. They are anecdotal figures and anecdotal things which say that she's 120 years smoking continuously. And I hate this because in next 5 minutes, you are going to know what are the bad effects of tobacco on the heart. If you smoke or take any form of the tobacco, especially smoking, it progresses your atherosclerosis. And what is atherosclerosis? The cholesterol which is deposited in your cardiovascular system. It causes a coronary artery disease because if you smoke, your atherosclerotic plaque, which narrows the artery of the heart, can suddenly rupture. It becomes soft, vulnerable plaque. So there are more chances of myocardial infarction and sudden cardiac death. People who has a coronary artery disease, who are a heart disease, if they continue to smoke, even after revascularization, they have underwent bypass or angioplasty, but if they continue to smoke, it leads to more stent thrombosis, more stenosis, and more chances of acute or recurrent heart attack. It increases the stroke. It is very well known that stroke increases when you continue to smoke. The most important predisposition of smoking is peripheral artery disease, and it is very, very closely related with the smoking. Chronic smoker has more peripheral artery disease. There's an abdominal aneurysm. Abdominal aortic aneurysm, if not treated properly, it's a very fatal disease. So there's a direct link with a smoking of cigarette with abdominal aortic aneurysm. And the most important thing, the second-hand smoker. You are not smoking, but somebody is smoking in your room, you become second-hand smoker. And it also increases the risk of cardiovascular disease and stroke. Now, this, whether it's an acute tobacco intake or a chronic tobacco intake, it increases your heart rate, basal heart rate. Initially, it is presumed that it decreases acutely your blood pressure, but ultimately it increases your blood pressure. It is a cardiac stimulant, so it increases the cardiac output and it may cause coronary steal phenomena. It causes coronary and cutaneous vasoconstriction. So if you have an atherosclerotic plaque in your coronary artery disease, it further causes vasoconstriction and it can lead to angina or acute coronary syndrome. Endothelial injury, those who smokes, it is being shown that they have endothelial dysfunction. There's increased serum catecholamine level, which has all adverse effect in cardiovascular system. It causes deranged lipid profile, your LDL increases, your good cholesterol decreases, and the most important thing, variety of platelet activation. And I think Dr. Tulika will definitely give you detail how platelet dysfunction occurs and which increases the thrombosis. And if you quit smoking, these all are the cardiovascular benefit. It reduces the markers of inflammation. It reduces hypercoagulability. It improves your HDL level. It decreases your LDL level. It reduces the development of subclinical atherosclerosis and decreases the progression of atherosclerosis. It reduces the atrial fibrillation. It reduces sudden cardiac death. It improves your heart failure. It reduces the risk of disease and death from the cardiovascular disease. It reduces the risk of coronary artery disease as such. And when you stop smoking, it starts falling within 1 to 2 years after cessation. Reduction the risk of disease of death from stroke, from peripheral vascular disease, so on, so on, so on. And it definitely reduces the venous thromboembolism and peripheral vascular disease. 13 smokers need to quit to save 1 life post-MI, and that is a very well published data. So NN need to treat is only 1. The risk of recurrent myocardial infarction is markedly decreased by smoking cessation compared to who continue smoking after acute myocardial infarction. So we all know that it improves, but the improvement takes from 2 years to 20 years. And I'm going to give you data. This is a recent published article, association of smoking cessation with subsequent risk of cardiovascular disease. And this is about 9,000 patient study conducted for about 20 years. And what they concluded, among heavy smokers, smoking cessation was associated with significant lower risk of CVD within 5 years. And the risk after 5 years continue to decrease till 20 years. Again, a study, 3 major atherosclerotic disease, cardiovascular disease, stroke, and peripheral artery disease, and 13,000 patient study. It's a clear association with smoking, and smoking cessation definitely improve. However, peripheral artery disease risk need 30 years to stop smoking. The coronary artery disease, up to 20 years, it become as to non-smoker. Again, who has a first myocardial infarction? It concluded that it is the most important drug therapy prevention of smoking or cessation of smoking, and it benefits more than a pharmaceutical treatment for major risk. So smoking is one of the most important thing, cessation of smoking in treatment of coronary artery disease. Now, the approach is always been discussed: self-help, behavior intervention, pharmacotherapy, combined strategies, and I think nicotine replacement can be used in a person who are smoking and cannot quit smoking. E-cigarette should not be discouraged. E-cigarette is not good. However, acute nicotine replacement therapy has not so much adverse cardiovascular effect, and study has shown that it doesn't increases the risk of myocardial infarction. Clonidine, SSRI, Zyban, and this is beyond my topic. And there's a very good randomized control trial in patient of cardiovascular disease, and they find that varacillin and bupropion has a maximum effect of abstinence from tobacco or nicotine. Nicotine replacement therapy was inconclusive. Individual counseling, telephonic therapy were both more efficacious than usual care. So in cardiovascular also, it is very, very effective. Now, the comorbidity should always be taken into the account. If a cardiac patient has got a comorbidity coming from a deprived area with a mental health, it is very difficult to quit smoking. The withdrawal symptom need to be known of nicotine, because this all withdrawal symptom will increase the symptoms of cardiovascular disease. Quitting, everything works. Nicotine gum works, patch works, hypnosis works, behavior therapy works, and varenicline works. However, at 6 months, 80% relapse and is there in this intervention trial. So most cardiac patients are very determined to quit when they have an acute coronary event. However, they rarely quit successfully. So quitting, overall combination of strategies is always best. Behavior plus replacement therapy is good. And this is my last 2 slides. This is a very good 1 slide chart for patients who are a coronary artery disease and who are a smoker. So these are the stages for which you have to assess, use status, assess, advise, offer, and follow up. If the patient is smoking, you should know that how much he is nicotine dependent. If it's a nicotine dependent, number of cigarettes he is smoking, time to first cigarette after waking, prior patient trying to quit, give advice to quit now after offer treatment. All these therapies should be offered. If patient accept, follow him, because majority of the patient will have a relapse. But if patient decline, don't say no. In next visit, I will not going to tell him to quit smoking. In all your visit, you have to say him, quit your smoking, quit your smoking. So to conclude my talk, tobacco intake is associated with adverse cardiovascular outcome, both in patient with or without heart disease. Quitting tobacco significantly decreases the cardiovascular outcome in both normal patients and patients with cardiac disease. The quitting mainly involves combined therapy. However, relapses is very common. So when you are advising these patients, you have to be very cautious. Thank you very much for your kind listening.
Thank you, Professor Jadhav, for your very short, nice, and informative presentation. We can take one or the two questions for this session. If there are no questions, we thank Professor Jadhav once again, and then we now move on to the last presentation of this session, oral health and then tobacco cessation. May I request Dr. Pravesh Mehta, Professor and Head of the Department of Maxillofacial Surgery, Lady Hardinge Medical College, New Delhi. Professor Mehta, please.
Good evening, sir. Good evening, Chairperson, Madam and sir. It's a pleasure to be associated with the Quit India movement or the conference on tobacco cessation. And I being a oral health professional, a maxillofacial surgeon, so my perspective would be more on the chewing form of tobacco and how the oral health professionals could be involved in the tobacco control. Can I share my slides? Okay. It's initially I would like to thank the organizers of the Indian Society of Cancer Oncology and my friend Dr. Abhishek for giving me an opportunity to share my views about the tobacco cessation activities that need to be carried out. And just one second, yeah. So I thank the organizers initially, and I would like to take a different perspective. I would like to enlarge the tobacco quitting part and involve the oral health professionals also with a concept. As you can see, it is the WOW concept. WOW, why? Because the O stands for the oral cavity, right? And I'll tell you how it involves the oral health professionals there. So my slides would include about some introduction, the history, forms, benefits, what is the role of oral health professionals, and how do we act as leaders along to conclude of these slides. We all know, and previous speakers have also talked about tobacco being the most common or important preventable cause of mortality and morbidity globally, not in India also. It has been considered one of the strangest human behaviors which is necessary neither for the maintenance of the life nor for the satisfaction of the social, cultural, or spiritual or daily health needs of the individuals. In spite of all these factors, majorly with tobacco, it continues to be an important public health issue in our country as well as globally. Every year, more than 8 million people die from tobacco use. And I said this is the most preventable cause of death that you can have. Most tobacco-related deaths occur in low and middle income countries like our country. Smoking and exposure to secondhand smoke kill approximately 9,26,000 people each year, whereas smokeless part of tobacco kills an additional 2 lakhs in India each year, accounting to 74% of the global burden of smokeless tobacco in our country. Basically, the smokeless part of the tobacco is a problem in our region, the Southeast Asian region, and mainly our country. Of course, BD and cigarettes are there, of course. When you look at the history, I think people have covered that. I'm not going to, but two things. It goes back to a lot years back, more than 500 years back, when in 1492 it was introduced to Christopher Columbus when he landed in America. And subsequently, these Portuguese, they brought it to the Indian state when Akbar was the emperor around 1600 AD. And he used to enjoy that. And after that, it became a trend in our country, going into the culture form also, as well as a religious activity, the using of tobacco. Now, tobacco in our country is used in various forms. Could be smokeless form, could be smoked form, could be used as chillums, where you put into the or put in the water also, and you have the tobacco water. So there are various forms that you could use tobacco as. But are there any benefits? Yes, the benefits of tobacco cessation and not of tobacco use. So when you start quitting the habit of tobacco use in any way, within minutes to around 10 years, various activities on your health change. Same way, if the time of quitting is at 30 years to any amount of time after 60 also, the benefits in comparison is much, much higher. Your life expectancy increases over the period that you tend to quit the habit of tobacco use. But why, if everybody says that, then what are the pitfalls of cessation? Why don't people quit this habit initially or in the phase that they have been told by some of their colleagues or family members on society or the health professionals? First and the foremost, lacks the lack of knowledge, which we need to address in a major way. I'll come to that in the next slide. Nicotine dependence also is there. The person wants to quit, but he says, I've got that urge to take something and I require a doctor. If I cannot take it, I feel something, my head is spinning. I don't feel normal there. The other part, deeply ingrained cultural habits. As I said, it started in India when Akbar was the emperor, and slowly it has become a cultural and religious habit in our population around the country, especially in rural areas. Next, the lack of tobacco cessation motivation, advice and support. There is not, as I said, people have said about that, about using tobacco helplines, everything. But I need to tell you one thing. We have learned during the COVID times, it was all said to be maintain social distancing. It is not social distancing. You need to maintain the physical distancing always and socially be active. Similarly, when you want your patients to start quitting the habit, you have to get in touch with them, motivate them subsequently, every time, interruptedly. And it has to be a long process. Almost every 2-3 days, 5-7 days, it has to come back to him so that he knows that somebody is with him, support his movement of quitting the habit. The other is, there is no tobacco initiative by health professionals. When you talk about webinars, fine, this is good enough. We've learned from the COVID times to have webinars. But unless we go out in the community and we have interactions or we show people who have suffered the problems of tobacco use, I think then only it carries an impression on the patient's mind or the person who is suffering with this habit. And of course, the health profession's own use of tobacco. Many of us health professionals use tobacco in some form or the other. I mean, the patients come to you and he tells, and you advise him that your problem is basically a tobacco use problem. You have to quit it. He looks at you and he says, Doc, you are already smoking or you use a pan or something like that. Or you're telling me to do it. What is the problem? Initially you quit, then I'm there to support you. So these are the pitfalls of cessation which we need to address. And I said, initially in my slides also, that knowledge is the most important thing. Without knowledge is no value unless you put it into practice. So initially gain that knowledge, and of course, to open any lock or to have any solution to this problem, you have to have a key. And the key is the knowledge that you need to require before you get in the community, asking people to quit or treating these patients up. Now, these are the various effects of tobacco. Could be from recessions or cervical caries of the teeth around, to be tobacco stains, could be smokeless tobacco use with abrasions, could be hairy tongue, could be tobacco pouch keratosis, where you start putting the chewing form of tobacco at the sulcus of this mucosa, could be oral submucous fibrosis. This is a major concern in our country, especially the Southeast Asian region and our part of the world, which is mainly due to betel nut chewing and tobacco use. The other being the homogeneous forms of leukoplakia or leukoplakia in the lingual mucosa, or the orthoplakia involving the buccal mucosa, as you see in the slides. So it could involve any part of the oral mucosa. Could be the tongue, could be the palate, could be the buccal, could be the lingual mucosa. Anywhere it will involve and ultimately turn into malignancy. Because these are all conditions, that is pre-cancerous conditions. And if you can diagnose it during this stage, when it is not cancer, when it is not malignancy, and start the treatment, then and then only these patients can be helped and cancer can be prevented and the mortality and morbidity can be lessened, burden on our society. Now, what is the role of oral health professionals? As I said, the wow effect. Why did I say about the wow effect? The wow, as I said, O stands for the oral cavity. So when the patient comes to you, right, the first thing that you ask him, okay, what is it? He'll open his mouth to say something or to open his mouth to let the oral professional view his oral cavity, and that time the patient or the person cannot say anything when his mouth is wide open. And that is the time when the oral health professional can screen his oral cavity for any precancers or any cancerous lesions in his oral cavity and motivate him and start therapies as soon as possible. But the problem lies in our countries. Our oral professionals normally are trained, I would say. They are trained, but they are not paid for this. Like when a patient comes to you, he is trained to see that lesion, a leukoplakia or oral submucous fibrosis, but the problem that the patient has come with is basically a carious tooth or a bleeding in the oral cavity or an ulceration. He will treat the ulceration because he's getting paid for it. For the quitting of the habit, since he's not getting paid for it, that habit becomes a secondary effect of management of patient care. So 8 steps of oral examination should be explained to the patient, because patients can normally do an oral cavity examination himself or herself by looking at the mirror directly and doing that examination. And if they find any ulceration for more than 14 days or any trismus or any blanching or any burning sensation, he need to go back to his oral professional and start therapy as soon as possible when that problem is an oral potentially malignant disorder and not turned into cancer. Why do we say about these conditions, that oral pre-malignant conditions? As you see that lower part of the screen there, when there is hypoplasia, okay, there is no amount of invasive cancer till the time of in situ cancer is there. So till that time of in situ cancer dysplasia, if we can diagnose these conditions, which are basically called as oral potentially malignant disorders or precancers, the cancer can be prevented, because we can start the therapy immediately. We can ask the patient to quit the habit and monitor this patient. So as soon as the cancer develops, we can operate on him or put him on radiotherapy or any therapy that is required for him. So the disease or the mortality or morbidity of these patients can be prevented in the times to come. So as we all know, tobacco cessation approaches, there are many regulatory approaches the government will do. Service and the education is our part, and that is where oral health professionals could be involved in tobacco cessation in patients. Because to do well in our practices, we should know our patients and what they expect. Because the patients might need many things, but the doctor has to analyze that what does he want out of it. If the patient comes to us with a burning mouth syndrome, instead of putting him on some analgesics or local topical application of some anesthetics, why not see his history? Why not ask him about quitting his habit of tobacco use or betel nut use, so that the prime concern, the prime issue out of the causative factor can be removed from there, because what gets measured will get done, and what's get done gets rewarded, and what gets rewarded gets repeated. And that is why we can control the oral diseases in our population. And we can act as leaders. We've done that program for the Government of India, Ministry of Health and Family Welfare for the last 7 years at the Pragati Maidan India International Trade Fair, where our Department of Dental and Maxillofacial Surgery at Lady Hardinge Medical College was involved with the government, and we were doing that survey for the people for oral examination, just for oral or a dental screening examination. And these people used to come to us, and on the way we should ask about the habit and screen their oral cavity. If we found approximately every year around 50 to 70 patients suffering with oral potentially malignant disorders, and they said, yes, we have this problem, but we don't have any cancer. So we told them that you have to follow this up, you have to quit this habit. We called them to a department, and out of 50 to 70 people, roughly around 45-50 came back to the hospital, and around 80% were prevented by cessation and starting therapy as soon as possible. Similarly, we've carried out campaigns in schools of Delhi government and central government also in the region of Delhi NCR. We've taken no to tobacco initiatives of population, convinced them both at our satellite clinics at Kalyanpuri and at Palam House also. This is one of the slides that we have there for the examination that we do there. We've launched a helpline number also on dental oral health, which you all can go around and have a screen of it and give a feedback on it. The number is very simple to remember. It is 1800112032. Now, why this specific number? The reason being, 1800 is a toll-free number, 11 is a Delhi region number, and 2032 sends a message that 32 are permanent teeth a human being has, and 20 is a set of milk teeth that the child below the age of 5 would have. And we have named this number as MOH Seva. or the Muh Seva. Why a Muh Seva? Because it's a mobile oral health seva which you can dial from any mobile or a landline number, and you could talk to the computer there where information has been given 24 into 7 into 365. The second initiative that our department has taken, that we've been designated by the Ministry of Health and Family Welfare as a National Resource Center or a PMD hub, that is potentially malignant disorder hub for the country. And we recently got that. I think next month or two we will have the inauguration, and then we will make protocols for a country to follow these. So dental practices will increasingly move from more of restorative orientation to one of broader promotion of health and well-being. And this is unconscionable to not include the aggressive tobacco intervention in that new paradigm. Because if we do not include that tobacco cessation part, intervention part of it in our patient population, we advise them, then we are not going to control oral diseases in the times to come. So with this, I'd like to thank you all for your pleasant hearing of my thing and my views regarding tobacco cessation in our part of the globe involving oral health professionals. Thank you so much. We can do it and we will do it.
Thank you very much, Professor Mehra, for such a lucid presentation on the various effects, the oral effects of tobacco. And I'm sure it justifies a restrictive policy at its, at limiting its usage. And I'd like to appreciate in your talk is one is that many people who are using tobacco, perhaps because of their limited understanding of the magnitude of the problem that they are in. And secondly, being a role model, we as doctors can be a role model to our patients and to the environment that we are. So with this, I'd like to invite our next speaker. Our next speaker, a dear friend, Dr. Tulika Seth from the Department of Hematology, Clinical Hematology from AIIMS Delhi. Over to you, Tulika.
Thank you. Thank you so much. I will now share my screen. So the topic, I hope my screen is visible. So the topic assigned to me was tobacco and hematology disease. Now this is less well defined than the previous speakers who have given a lot of data. So my talk is going to have a little data and a lot of descriptions. Now, we know that cigarette smoking can cause hematological abnormalities. And we know that these abnormalities have also been associated with coronary heart disease. And Dr. Rakesh gave a beautiful talk, so I won't go into that too much. But basically, it is due to platelet activation and increased inflammatory markers. So what exactly are these hematology changes that we see in smokers? So you can see an increase in the red blood cell count. There is an increase in the hematocrit, also called packed cell volume, and the hemoglobin. And these red cell indices, when you compare them with non-smokers, are significant. Now, other markers like the red cell indices like MCV and MCHC are also increased, but not to such a marked degree. So red blood cell changes are very common and occur in almost all smokers. Now, there are several studies, even in the West, where they've looked at this. So the first study that I showed was a smaller study from Pakistan, and this is a very large study that they did in more than 10,000 patients. And here they also found that along with the hemoglobin and the red cell indices, they also found that there was an increase in the white blood cells. Now, for all of you who are aware of coagulation and in polycythemia, it is not just the high hemoglobin, but it is also the high white blood count, which contributes to the thrombosis. So this was a large population study. Now, people will say that there may be errors in doing such a study because you may be just looking at certain populations, and then whether people are smoking regularly or not may not be very well known. And so an even larger study was done, and this is from Denmark, where they looked at certain polymorphisms in genes which are related to genetic variations that cause high tobacco consumption. And they did this because there are otherwise in the previous studies, there could be some problems because obviously in looking at white blood cell or red blood cell changes in smokers, you can't do a randomized control study. And other cohort studies or cross-section studies have limitations. So doing this Mendelian randomization, they did a very large study where they had over 1 lakh Danish people with a wide range of ages, and they compared the smokers and non-smokers, and they found that almost all of the hemoglobin, white cell, platelet, all parameters were increased, some markedly, such as the leukocytes in the hemoglobin, and others to a lesser extent, like some of the red cell indices. And with this observational study, they were able to show that there was a significant change. Now, the other interesting thing that was found in this was that when the smokers stopped smoking, the hemoglobin changes rapidly reversed, but the white blood cell changes took a very long time to reverse. So this shows that even with smoking, all of the changes that are there do not disappear once the patient stops smoking. And this is important to know, so that especially patients who quit smoking and then restart smoking again, it's going to take them a very long time to reverse some of the white blood cell changes. Now, the biggest thing that we are all worried about in hematology are malignancies, and acute myeloid leukemia has also been associated with smoking. And this was one of the studies that I was able to come across, though there are many reports, and there is a relative risk which shows a trend of acute myeloid leukemia. So the more smoking that was done, the higher was the risk in patients. And of course, this is a case where stopping smoking is not going to help the patient. So once you've developed acute myeloid leukemia, this is now irreversible. Though there are still some questions about exactly how serious acute myeloid leukemia. We all know that the cigarette smoke has a lot of chemicals, so which exactly are the culprits not known. We do know that different types of leukemia can be there. So again, it's not clear whether there's one particular type of AML or is it a secondary AML. So there's still some questions to be answered, but there is definitely a correlation. And we also know that the toxic chemicals in the smoke increase the micronuclei formation and chromatid exchanges, particularly in the lymphocytes and the myeloid cells. And as we said, the white blood cell changes that are there are much more long lasting than the red blood cell or platelet changes. So the other thing that is found is high platelet counts. And I just wanted to talk about this because we often don't talk about high platelet counts in our country. And there are several cohort studies that have shown that patients who had persistently elevated high platelet counts often developed solid tumors within a short period of time. And this correlation has been seen in many studies, and it's been seen with lung cancer, with colorectal cancer. And the exact mechanism is not known. It's not known whether the platelets themselves promote the cancer or whether they release different growth factors or anti-angiogenic factors. But this correlation is definitely there. It is there to such a degree that the NICE guidelines in the UK state that in males or females, if there is a persistent high white blood count, they should be screened for cancer. So if it's a male or female of 55 years or more with a persistently high platelet count and GI symptoms, they need to be screened for esophageal or stomach cancer. If it's a person who's over 40 years old and is a smoker with persistently high platelet count, they need to be screened for lung cancer. And in women who are 55 and over with thrombocytosis, that's a high platelet count, and unexplained gynecological bleeding, they need to be screened for endometrial cancer. So this is something that can be a marker. And in fact, they made an acronym called LEGO, which is lung cancer, endometrial cancer, gastric cancer, and esophageal cancer. So patients with thrombocytosis should be screened. Now, many of these patients could be smokers, and there is obviously a risk of and a link of these. Now, if it's not cancer, then it could be essential thrombocytosis. And these patients often have a delayed diagnosis of essential thrombocytosis. And we know that patients who have a high platelet lymphocyte ratio, if they have a solid tumor, often have poor prognosis. So all of these high white blood counts, which could be related to smoking and the consequences of smoking, have significance. The red blood cells, we know that smoking itself can release many compounds, including carbon monoxide, and lead to polycythemia and secondary cythemia. Though it has less risk of thromboembolism than primary polycythemia vera, which is a myeloproliferative disorder, but it does have a significant risk of cardiovascular disease as well as cerebral stroke. So stroke and cardiovascular disease are increased even in patients with secondary polycythemia vera. And the high white blood count we already talked about. So patients who have a high white blood count, many times they may have a myeloproliferative disorder, but it could also be due to smoking. And even in patients where they have stopped smoking, the white blood cell changes can persist for up to 2 to more years after stopping smoking. So these are some of the important things that we need to be aware about. Now, cessation of smoking, there are not very many studies of hematological diseases, but these reversal of hematological changes can occur sooner with white blood cells, but much delayed, up to 2 to 5 years in patients who quit smoking. The lymphocytes and monocytes will still demonstrate the abnormalities. Okay, so that's the end of my talk. Thank you.
Thank you, Dr. Tulika Seth, for your nice presentation. And I fully agree with your opening remark that this subject, the impact on hematological parameter, is less discussed even among the doctor. Thank you for your presentation. And then we can take one or two questions if the organizers permit. If there are no questions, then we thank you once again for your nice presentation. Thank you.
Thank you.
We now move on to our next speaker, Dr. Vatsala Tatwal, who is also a professor in the Department of Obstetrics and Gynecology at AIIMS Delhi. And she'll be talking on the effects of tobacco on girls, women, and pregnancy.
Thank you, Dr. Sushmita. May I share my slide, please? Okay, I think there's some problem. Can you share, put my slides on, please? So I would be talking about tobacco cessation as far as girls, women, and pregnancy is concerned. Can I control this? So effect of smoking in women, it affects her entire lifespan. And what is different here is that it affects her fertility. We have to consider about the effect of tobacco and smoking on pregnancy, the fetus while she's breastfeeding, and the health of her infant and children who may be exposed to passive smoking. And when we talk about cessation of tobacco in women, does it differ from men? So we know that there was a survey in 2016 which showed that 20% of adult women use tobacco product, and 90% of these 90% are using smokeless tobacco, and around 6% of pregnant women in India do smoke. So when we talk about smokeless tobacco, 12% of women aged 15 years or more are using smokeless tobacco. And again, in pregnancy also, 4 to 7% women use, and 5% of lactating women use smokeless tobacco, which is a big burden among women. And we understand that women who are of low socioeconomic status, poorly educated, who don't know about the knowledge of, who do not have the knowledge of the health effects of tobacco, and who have their partners who use tobacco are more likely to use tobacco. And why women use tobacco? Because they think it is going to reduce the stress, provide pleasure, companionship, to provide energy for workload, suppress hunger. And also in pregnancy, they use smokeless tobacco because they think it's going to relieve them from common pregnancy problems like nausea and vomiting. So as far as fertility is concerned, smoking increases the chances of infertility. These women are likely to have pregnancy losses because of implantation problems. Not only these, the fetus is exposed to tobacco in utero. When they grow up, they're more likely to have infertility themselves. So the toxic substances present in the smoke, it affects the ovarian follicles. It is also mutagenic, affecting the gametes, and that may lead to abortions and malformations too. And as far as postmenopausal women are concerned, we know that at a higher risk of osteoporosis if they smoke, and consequent increased risk of fractures. So I'll focus a little more on pregnancy. So the risk in pregnant women are increased risk of abortions, ectopic pregnancy, placenta previa, abruption, preterm births. And as far as the fetus is concerned, there's increased risk of malformations, especially orofacial, clefts, neural tube defects. Even passive smoking increases the risk of malformation. The babies born are small, growth restricted, so have increased perinatal mortality. And smoking also increases the risk of sudden infant death syndrome. Not only these, the children who are exposed to smoking or tobacco in utero have neurological developmental issues. They're at a higher risk of autism, attention deficit disorders, respiratory problems, childhood obesity. And also children of the mothers who smoke are exposed to passive smoking and are more likely to have respiratory illnesses. So coming to quitting, like stopping smoking. So if we compare women to men, the same study, which was conducted in 2016, a global sort of survey, showed that the percentage of women who attempt quitting are lower than men. The percentage of women who are advised by healthcare providers to quit are less compared to men, and less number of women are willing to quit smoking. And women who attempted to quit smoking, it was shown that only 70%, it was a self-motivated. Very few really used pharmacotherapy or went for counseling. Pregnancy is a good time to motivate or counsel a woman to stop smoking because she's motivated. When we talk to her about the ill effects on her pregnancy and the fetus, she is in frequent and regular contact with the healthcare provider. So there are multiple opportunities to assess and reinforce abstinence. And we can also educate the women's relatives who accompany her. So definitely there is a role of clinician. It starts with asking women whether she is using any tobacco products, looking into the psychosocial behavioral issues with the woman, and planning for a behavioral intervention, see if she requires pharmacotherapy. So as far as the role of healthcare professionals is concerned, the American College of Obstetricians and Gynecologists say that all obstetricians and gynecologists should follow 5 A's of tobacco and nicotine cessation. First, ask the patient if she's using any tobacco or nicotine. This could be smokeless or cigarettes, and in any form, because sometimes women may not recognize the non-smoking or smokeless tobacco use as harmful. Then counsel the woman, tell them about the adverse effects, and advise them to stop smoking. And assess if she's willing to quit. If she's willing, then chart a program for her for quitting smoking. And if she's not willing, look at the barriers, see if she has any mental health issues or other psychosocial factors which need to be taken care so that she can be motivated to quit. Assist her, help her out with pharmacotherapy, with behavioral therapy, and arrange follow-up visits, see if she's following your advice. If she has given up smoking, encourage, otherwise keep reinforcing the good practices. So as far as pregnancy is concerned, so when you talk about saying behavioral, as far as pregnancy is concerned, behavioral therapy is very important. So important to advise her regarding the effects of nicotine or tobacco. It could be face-to-face counseling, talking with like the healthcare provider, talking to the pregnant woman, or the counselor talking, using audiovisual aids or other educational material. So as far as pregnancy is concerned, or otherwise also, behavioral counseling remains the cornerstone. It is very important to understand that addiction to tobacco is physiological and psychological and affects on a whole lot of psychosocial factors which we need to understand. So there are different types of counseling and aspects of counseling like motivational counseling, cognitive behavior therapy, psychotherapy, relaxation techniques which will help. And also the women have to be educated to manage their cravings, situations of stress and anxiety, promoting self-efficacy, asking them to set their goals and plan out the action for cessation is very important. And in a meta-analysis, it was found that counseling increased smoking cessation in pregnant women compared to usual care. And these women were more likely to be continuing abstinence 5 months postpartum. Other benefit was reduction in low birth weight and decrease in nursery admission of the newborns. Again, not to to re-emphasize, it is important to look at the comorbidities like anxiety, depression, and if there is any other substance abuse, these also needs to be handled or looked into if you really wanted to give up smoking. Individualize the psychotherapy or the behavior therapy for her, involve the partner or the relatives. That will also be a great help to her. So if counseling doesn't work or in certain other group of women, pharmacotherapy may be required, especially heavy smokers who have had unsuccessful attempt in earlier pregnancy. Again, there is always concern about using drugs in pregnancy. So they may be delayed until second trimester and the organogenesis is over. Two commonly used drugs are nicotine replacement therapy and bupropion. Both are reasonable options because there's not enough data to show which works better. So what are the different society guidelines? The American College of Obstetricians and Gynecologists say that yes, behavioral therapy is the cornerstone. Nicotine replacement therapy may be used with proper counseling to the women. And again, there is not much evidence for the use of bupropion in pregnancy and lactating women. The European Network for Smoking and Tobacco Prevention are not in favor of pharmacotherapy. The United States Preventive Task Force says behavioral interventions are advised. Not enough data to advocate pharmacotherapy for cessation of smoking in pregnancy. But if we have to use the drugs, so nicotine replacement therapy is commonly used in adjunct to behavioral therapy. And in a meta-analysis, it was found to favor smoking cessation compared to, but in a subset analysis, women using nicotine replacement therapy versus placebo, there was a non-significant trend towards benefit in cessation of smoking, but there was no difference in outcome like miscarriage, stillbirth, preterm birth, etc. There is no strong evidence that pregnant smokers who use nicotine replacement therapy are at higher risk of adverse perinatal events, including teratogenesis, and administration remains the same as in non-pregnant adults. And again, we know that nicotine also crosses the placenta, so there are concerns about the effect on the fetus. So women may not use the patches at night to avoid continuous exposure, and they can use the various forms that are available. Coming to the other drug which has been used is bupropion, which is an antidepressant. Observational studies have shown that it is effective for smoking cessation in pregnancy. Again, it crosses the placenta, but the data on fetal impact are limited and inconsistent. Again, the effect of the drugs can also be, or this like sort of adverse effect or efficacy can also be confounded by factors as mother's mental health and use of other antidepressants. There's some concerns about cardiac defects in the fetus. In breastfeeding women, again, if she is smoking, it may affect her initiation of breastfeeding, and exposure to infant to passive smoking is always there, and the management is in similar lines as in pregnancy. These drugs are excreted in the breast milk, but to a small amount. But again, then we have to see the benefit versus risk, and then accordingly counsel the woman and prescribe the pharmacotherapy if required. So just to sort of conclude, definitely there's a lot of work need to be done, because as obstetrician gynecologists, we also not screening our women regularly in our clinics. Neither do we screen a pregnant woman. So we have to start screening them to see if they're smokers or they are using any tobacco products before we can implement any method of cessation. Again, we have to have more initiatives which are gender sensitive, and we need to have more data on like sort of like smoking as regard as gender. And also we need to have more information on special group like women who are lactating, pregnant women and elder women. We need more information about why the precipitating factor, the psychosocial issues which lead to the women to smoking, because all these are required to understand and develop a useful or a more effective behavioral therapy, which is an important cornerstone for cessation besides pharmacotherapy. So I would conclude with that. Thank you.
Thank you, Dr. Vatsla, for such a beautiful presentation. It's not only important in girls, but also during pregnancy and also after pregnancy during breastfeeding. So at no point of time it is too late to quit smoking or any other tobacco use. Thank you very much for the wonderful presentation, and thank you organizers for the event and for the session today.
I take this opportunity to thank all the participants of this session. And then I also thank Dr. Abhishek Shankar, chairperson of the organizing committee, for giving us an opportunity to share this important session. I'd also like to bring it to the attention of everybody that recently Honorable Health Minister of India has released the Global Youth Tobacco Survey report of the 2019. And then this report has shown that in the school-going children in the age group of 13 to 15, from the 2003 onwards, prevalence of tobacco consumption is gradually declining. But then alarming fact is that it is still alarmingly high in the northeastern part of the country. And in northeastern region, we have seen that about 25 to 35% of all cancer in women and about 50% of all cancer in men are tobacco-related cancer. Therefore, there is a lot to be done so far: the awareness, advocacy, tobacco cessation, and then implementations of the COTPA are concerned. With these remarks, I thank the organizers and once again the speaker. It was nice to co-chair this session with Professor Susmita from All India Institute of Medical Sciences, New Delhi. Thank you once again for patience here.
Thank you, Chairperson, and all the speakers for this very informative session. Now, I would like to invite Dr. Kunal Kishore to proceed for the next session. Over to you, Dr. Kunal, sir.
Okay. Thank you. Good evening, everyone. Hello. May I go ahead?
Yes, sir.
Yeah, good evening. Good evening, everyone. Now coming to session 6, and the chairpersons are Dr. Sachidanand G. Bharti and Vikrant Kaushal. Dr. Sachidanand G. Bharti is additional professor of onco-anesthesiology and palliative medicine at AIIMS New Delhi. His area of interest is thoracic anesthesia, head and neck cancer, pain management, ultrasonography in perioperative medicine, oncological, critical, and palliative care. He has 51 peer review in index journals, and he has contributed in 3 book chapters, and he has 5 abstracts. And Dr. Vikrant Kaushal is associate professor and head Department of Radiation Oncology, Lady Hardinge Medical College and Associated Hospital, New Delhi. So now over to Dr. Sachidanand Bharti.
Thank you, Dr. Kunal. And for this session 6, we have 3 interesting topics. Number 1 is tobacco cessation after cancer diagnosis. Second one is community-based tobacco cessation. And third topic is progress in tobacco control in the Southeast Asia. So for the first talk, I would like to invite Dr. Supriya Malik. He is Assistant Professor of Radiation Oncology at National Cancer Institute of All India Institute of Medical Sciences, Jhajjar. Dr. Supriya has more than 150 publications in peer-reviewed index journals. One of the most promising young radiation oncologist of AIIMS. Without wasting time, I will invite Dr. Supriya for his talk. Dr. Supriya, please.
Good evening, sir. Good evening, the organizers. At the outset, I would like to thank Dr. Abhishek for this beautiful opportunity. It's beautiful evening outside, all cloud, and we are discussing about tobacco, and which is really quite hazy. Let me share my slides. Yeah, here. So in last the previous speakers has made it quite clear that tobacco is not a new thing to us. We know it for years, and also we know the harmful effects of tobacco for years. We know that tobacco is associated with multiple diseases, and the previous speakers has enumerated it very well. Now, we all know that it has direct implication with the incidence of cancer, but still in different countries across the globe, it is consumed in different forms. It is chewed, it is smoked, and in India, it is so prevalent. Even if we travel from New Delhi to the new campus of AIMS Jhajjar, we see there are multiple stores with beautifully decorated hookahs. So hookahs, bidi, cigarettes, these are pretty prevalent in India. And the data says near about 70% of people in India, they smoke tobacco. The tobacco is harmful to not only the person who is smoking, but it has effects on the people surrounding. And data says that passive smoking kills 6 lakhs people every year. So whenever a patient comes to our OPD, whenever a patient we are dealing with, we know that his disease is associated with smoking, he has smoking history. We most of the times limit our interest to taking this history, how many bidi or cigarette you used to smoke for how many years, and that's all. The question comes, what should we do further? Should we ask the patient who has already been diagnosed with a malignancy to to stop smoking or not? Different times we see that this aspect of smoking cessation is totally ignored, and that may be because as clinicians we feel, what is the benefit of cessation now? Because the patient has already got the disease, there is no point of smoking cessation at this point of time. Some of the physicians, I already personally experienced few colleagues, they feel that the patient will have withdrawal symptoms. The patient is now not motivated for such smoking cessation. So why we need to push the patient towards smoking cessation? Rather, we should focus to the treatment. So these are the few salient features, salient points that we see every day in our practice. But the data is pouring in for the other side. The data is more and more indicating that cessation of smoking is important even after diagnosis of a cancer, because in addition to the general health benefits, it improves disease control. It may improve the progression-free survival, overall survival. It may reduce the toxicity. It may reduce the chances of second malignancy, and it should be done to deliver the therapy in the best possible way. So let's see how smoking is associated with complications of different types of cancer therapy. We all know that surgery is a very cumbersome procedure in the cancer patients. Most of the cancer surgeries are quite an extensive surgery, particularly in lung cancer. And the recent data says that compared to never smokers, current smokers had a higher frequency of post-operative pulmonary complications, 22% versus 2%. That's statistically significant. ITU admission, 14% versus 0%. In the ex-smokers, there was a trend for a lower frequency of post-operative pulmonary complications and hospital ITU admissions. So this data only good enough to indicate that if a patient continues to smoke, they will have more chance of complications, more chance requirement of ICU and ITU. So they should stop smoking. The data, of course, has already been highlighted in 2009 when the Society of Thoracic Surgeons, Surgeon General's database study also highlighted this issue. However, there is some amount of question from the Japanese group. They say that if a patient stops smoking only just 3 weeks or 2 weeks, the benefit may not be that great. But still, it is advised that patient should stop smoking, because after surgery, the patient will require radiation chemotherapy, and the implication and the interaction with radiation and all these therapies we'll see in the subsequent slides. Breast cancer, as we know, it is increasing across the country. All the metro cities in India, now breast cancer is the commonest malignancy amongst females. And we see that 41, the patients after a conservative surgery, because they get early diagnosis, they go for breast conservation and they require radiation. And 41% reported worse outcome in smokers than never smokers. And this data is not old, just 2020. The risk of radiation-induced side effects, namely reconstruction complications, skin reactions, are more common in patients who are smokers. In India, head and neck cancer, if we take together nasopharynx, oropharynx, oral cavity, hypopharynx, this forms the largest cohort, largest group of cancer patients. And data says that mucositis, need for feeding tube, duration of feeding tube, need for hospitalization, pharyngeal stricture, osteoradionecrosis, these are all pretty common with the patients who continue to smoke during their treatment. And this is significantly more and for need for hospitalization and osteoradionecrosis. Patients who continue to smoke were more likely to develop osteoradionecrosis as well. Let's see how it impacts adversely the outcome also. Smokers who continue to smoke during radiation have a significantly lower rate of complete response rate to the radiation therapy. With radiation, with smoking, it is only 45% compared to non-smokers, 74%. And 2 years survival also nearly double for the non-smokers. Recent quitters were more similar to long-term quitters than to continued smokers in survival likelihood at 18 months. Two big trials, RTOG 9003 and 10129, both by looking at oropharyngeal cancers, and they reported that smoking during radiation decreased overall survival and progression-free survival. The risk of progression or death increased by 1% per pack year smoked, or 2% per year smoking in both the trials, and both the data are significant. Let's see how it affects the lung cancer. For small cell lung cancer, all-cause mortality is increased, second primary rate increased, recurrence rate increased. The hazard ratio for second primary is 4.31. The estimated 5-year survival in patients continuing smoking is 29% compared to those who stop or who quit is 63%. In non-small cell lung cancer, the 5-year survival rate is 33% versus 70% for those who quit. Again, second primary rate hazard ratio is 2.29, all-cause mortality 2.94. Let's see a beautiful systematic review and meta-analysis published in 2020 that beautifully tabulated all the studies and the trials which went on to which analyzed the impact of continuous smoking on the outcome of head and neck cancer patients. And see, the sample size are quite significant, and we'll look at the survival outcome. The overall survival outcome for the quitters range between 55 to 68%, whereas for the continued smokers, it is 28 to 40%. And for most of the studies, that's significant. This is a prospective study and impact of smoking cessation on clinical outcomes for head and neck squamous cell cancer patients who are on concurrent chemoradiotherapy. And we can see that PFS and distant metastasis-free survival both are better for the patients who stop smoking. Those who continue smoking, their outcome is compromised. Smoking not only impacts the ongoing cancer treatment, but it also increases the chances of subsequent development of malignancy. The persons present with both smoking related and non-smoking related malignancy face increased risk of second malignancy at the same site or another site if they continue to smoke. And for a patients who get early diagnosis or like T1 laryngeal cancer, if the patient continues to smoke, the chances of development of a second malignancy is higher for him. In 2 studies of survivors of small cell lung cancer, risk of a second cancer was 3.5 to 4.4-fold higher, and mostly it was non-small cell lung cancer. In head and neck cancers, the chances of developing a second malignancy is 21% for those who continue to smoke versus quiters 13%. The risk of smoking-related second primary tumor is threefold higher in current smoker versus never smoker. Former smokers and recent quitters who remained abstinent from smoking during follow-up had a 1.5-fold higher risk of developing smoking-related second primary neoplasm. Local regional recurrence rate 66% for never smokers versus 59% for the quitters versus 44% for heavy smokers. Not only radiation, there is quite significant amount of synergism between the smoking and chemotherapy. Data says that the current smoking at diagnosis of Hodgkin's disease increase the risk of lung cancer, and the relative risk is 21.2. In current smokers with at least one pack per day habit, current smoking increase the risk of lung cancer in a synergistic manner when combined with cytotoxic treatment. And the relative risk is 20.2 for smoking combined with RT, relative risk of 16.8 when smoking combined with alkylating agent, and it is 49 when smoking combined with RT and alkylating agents. Not only this, because the data we are getting more and more, and the interaction of chemotherapy in the cellular molecular environment and nicotine and its environment is quite complex. Maybe another decade we'll be knowing better what is the implication, what is the interaction of tobacco with the molecular therapies, the cytotoxic chemotherapies, immunotherapies, and perhaps we'll get to a situation that patients will continue to smoke during their treatment, will have limited benefit of such therapies during their treatment. In 2020, United States Surgeon General report has been published, and which says that smoking cessation associated with 45% reduction in overall mortality and in the cancer patients. In an overall guideline, the US Journal has highlighted that smoking cessation is beneficial at any age. Smoking cessation improves health status and enhances quality of life. It reduces the risk of premature death and can add as much as a decade of life expectancy. Of course, this is not for the cancer patients, it's a generalized population. But what I want to highlight, the point 4, that smoking cessation reduces the risk of many adverse health effects, including different types of COPD, cardiovascular disease, and different, at least 12 cancers. That includes lung cancer, laryngeal cancer, oral cavity cancer, pharynx, esophagus, pancreas, bladder, stomach, colon, rectum. So smoking as such is harmful. It is a causative agent or a cause for different malignancies. It also causes imparts an harmful effect on the treatment. It increases the chances of complication. It increases the chances of radiation chemotherapy induced toxicity. So, and it also makes a patient vulnerable to develop a secondary neoplasm even after the patient gets cured of the primary malignancy. So all efforts should be made to to encourage a patient who has already been diagnosed with a cancer from smoking, because if they stop smoking, the chances will be much better for a better life in future. So there are different modalities available, and it should be tried on them. We should convey to the patients repeatedly so that they at least stop smoking. And if at least for some amount of patients get benefit, that will be a good achievement, and we should be continuing it always. Thank you.
Thank you, Dr. Supriyo, for your nice presentation, and you have nicely summarized the evidences which we have on the smoking and its effect on the cancer after its diagnosis. But I think the most of the evidences are with smoking, and very limited evidence is with the tobacco chewing, which is more prevalent in our country. So this may be an area of further research, how this has affected the cancer recurrence or cancer progression after the diagnosis. Now,
thank you, Dr. Malik, for your excellent talk. And now I welcome Dr. Vikrant Ranjan Mohanty, who is MDS Public Health Dentistry and also Associate Professor and Head of Department at Maulana Azad Institute of Dental Sciences. And he has contributed significantly to tobacco cessation related work, which includes starting a tobacco cessation clinic at the Institute in 2011. Dr. Vikrant Ranjan Mohanty will be speaking on community-based tobacco cessation. So over to you, Dr. Mohanty.
Thank you so much, sir. I just share my presentation. I hope my slides are visible. I'll just put them on the slideshow mode.
Yeah, they are visible.
They're visible.
Yes.
Yeah, you can see the slideshow mode, sir.
Yes, yes. And they are now on slideshow mode.
Yeah. Thank you, Dr. Kaushal. So at the outset, I would first like to congratulate and also thank the organizers for this pertinent talk on this whole conference that they have organized at these times, because one, we are coming out of COVID, and two, we are relooking at how exactly the healthcare system has responded and has to look forward into the future. So preventive healthcare has become a very important, I would say, a kind of strategy which is needed to to be relooked into and to be planned ahead, so that the response of future pandemics as well as disease would be better. So I represent the institution, and we actually started off, as Dr. Kaushal said, we started off with this single clinic in 2011, and currently, after 10 years of working in this area of tobacco cessation, today we've been recognized by the Ministry of Health and Family Welfare as the National Resource Center for Oral Health and Tobacco Cessation. And we have just started the work as a National Resource Center, and we'll be talking a little bit more about that also and during the course of the presentation. So I would start off this presentation by saying that if we do not focus on initiation of initiation, as well as only on initiation and not on cessation, at the end, around in 2050, we would have at least 160 million deaths among smokers. So most of the work that I think we have been talking about since yesterday has been more or less on smokers, and most of the Western world actually focuses on that. The WHO came up with this strategy of the FCTC, which is the Framework Convention, which is like an overarching principles of how to guide institutions as well as countries, primarily who are signatories to this FCTC, into working towards tobacco control under various strategies. They came up with this Empower strategy, wherein they need to monitor the various tobacco control activities and the various policies that are there in place, protect people from tobacco smoke, offer cessation services, provide warning labels and the pictorial warnings over tobacco products, enforce wherever these laws are implemented, and raise and work on taxation so that it becomes more and more difficult for people to buy and use this product. So these are the various strategies on which the WHO has been working. And since 2003 of this implementation, there has been a lot of progress. But even after that, almost 18 years since they've been implementing this, only currently 32% of the world's population has some access to all these strategies which we're talking about. So the Article 14 primarily talks about I would say talks about mainly about cessation and offer to provide cessation. And the four most important components that they focus, the Article 14 of the FCTC is to develop national cessation strategy and to develop national cessation guidelines, build capacity through training, and involve a recording of tobacco usage among all those patients reporting to the hospitals, and monitor and evaluate all these treatment strategies as well as review them from time to time. So these were the most important components that the Article 14 has been looking into. And the current status of this Article 14 across the globe, you can see that the different shades of blue indicate that only 17 high income countries out of almost I would say 60 of them have been able to implement national quitline. Middle income countries only 9, and none of them have implemented a national quitline in the low income countries. So on the right hand side, you can see that the various strategies that is there: availability of NRT, availability of cessation services, whether there is reporting of the information, as well as the availability of national quitlines, which are one of the important strategies when it comes to availability of these services in the country. So as my presentation is primarily on community-based, tobacco cessation strategies, I would be taking you through quickly through different aspects or interventions that have been tried, whether as an individual intervention or multiple interventions which have been done across the globe, but primarily what has been done in India. So whenever we talk about a community health, it is something which we have to look. See, most of us work in hospitals, and where these are centers where patients actually come on their own when they have certain problems. But when we talk about what is happening in the community, it is little different than what happens in a hospital or a healthcare setting. So the individual is influenced through multiple factors, and these factors may not be able to be measured or sometimes not visible also. So it becomes even more difficult when you have to plan a program for a community without knowing what is influencing. So, multiple surveys have been done in our country, the GATS 1, the GATS 2, which was in 2016-17. Recently, the Global Youth Tobacco Survey also was released, done in 2019. India has done tremendous work when it comes to tobacco control, but still, because of the huge population, because of the type of tobacco consumption patterns we have across our country, it becomes very, very difficult to contain as well as standardize the approach everywhere. So when you look at the various determinants of health as a public health, for a personal, so you would look at it from different angles. You would look at it at an individual level. You would look at it at a at a community level as well as a national level. And there are multiple things which influence the various determinants of these, mainly social determinants of health, whether it's education, whether it is income, whether it is occupation, whether it is food, whether it is employment, and all these factors play a very important role, and even access to healthcare. So all these things are very important when you have to plan something, and it becomes really very a big struggle. So what is more important here, whenever we talk about community based cessation programs, it is very important that we segregate and work in a very close context and try to have a similar group on whom we would like to intervene. Because even a community can be a village, a community can be a block, it can be a school, it can be any setting which has similar kind of people working, or or at least staying and having similar kind of living conditions. So that is what you have to keep in mind while planning these cessation community based programs. Another approach which is also very works very well is the common risk factor approach. This common risk factor approach is nothing but there are multiple risk factors which cause multiple chronic diseases or the non-communicable diseases. So the control and prevention of certain of these risk factors would result in control, and you benefit by controlling outcomes like diabetes, the outcomes like cardiovascular diseases, respiratory diseases, dental problems, and cancers. So tobacco is responsible for multiple outcomes. So if you control tobacco usage, you benefit by controlling cancer, by controlling the occurrence of heart diseases, dental problems, oral cancer, to go on. So that way, this approach is very important. So when you're planning a community health program, it is important to address or to plan keeping these factors: one, the various social determinants; two, a common risk factor approach; and three, obviously on the basis of what human resources you have to plan, and whatever resources you have, whether it is the amount of funding, the availability of human resources, and the other resources that you're looking at. So this is another strategy which we also have to keep in mind while talking about community health programs or community cessation programs. We all know about this, the downstream as well as the upstream approach. The downstream approach is mainly more clinically oriented, whereas the upstream approach talks about health policies, public policies, and implementation at a larger level. So it is very important that all these approach actually work in tandem. Otherwise, what would happen? The success at a clinical level would not actually contribute at a larger level. So the experiences that we have at a clinical level can be translated through certain experience sharing at a community or at a larger public health level. So understanding of all these aspects when it comes to community health programs is very important. We all know about the GATS report and the tobacco consumption pattern in our country. I would not go into details of that. But when we look at cessation, there is a huge burden of smokeless tobacco in our country, and you would see that the burden is much higher in males as compared to females. And similarly, because there could be various other reasons that we could list out here, whether it is income, whether it is occupation, whether it is working conditions, whether it is the stress levels. So you can start looking at groups and look at occupational groups who are exposed to different forms of tobacco. So similarly, they might be thinking about quitting, but they really don't know where to go. So all these details that have come out of the GATS2 survey are very heartening, because the numbers have increased. The tobacco usage has come down 6 points, but still 1/3 of the Indian population, that is almost 28.6% of the Indian population, still consumes tobacco. So there's a huge demand for this service, cessation as an integrated process. But we all have to remember that one strategy will not work. As our country is large, the requirement is large, evidence mostly is from the Western world, and we need to develop research and evidence from the local communities. Also, not wasting time, we need to start implementing things at a local level. So with regard to tobacco cessation clinics, started way back in 2002, went on, initially established by WHO and the government of India, went on to have around 19 clinics, but still these clinics were mainly located in tertiary care hospitals, and patients would be mainly apprehensive or stigmatized visiting these clinics. So it had to be, the NTCP came into existence in 2007-8, and on the ambit of NTCP, one of the main objectives was to enhance cessation services, and the National Tobacco Control Program has been successful. Almost 650 tobacco cessation clinics have been established, but we are far from what is needed for our community. So when we look at the community level, so there are certain interventions that we're talking about. To first start off with are the quit lines. So we are all aware there's a national quit line in our country. It started off in Patel Chest, the Vallabhbhai Patel Chest Hospital in Delhi, and now has expanded to different parts of the country. So WHO itself recognizes quit lines as a very strong intervention which can be promoted and can be made available, because telecommunication has increased and it has resulted in actually reaching out to the masses. So in the till 2017, they have received around 60,000 calls since they started just a year ago, before that. And the response was so much that the government had to relook into whether they had to open up more quit lines, and it resulted in opening up of more quit lines. And now we have quit lines located in Tata Memorial Hospital, Mumbai, in Nimhans, Bangalore, and in Guwahati in the the Boria Cancer Institute. So this resulted in huge amount of calls that have been attended. But one more issue with these quit lines was they ran throughout the, they had almost 12-hour shifts, and the counselors were very much there, well trained, but still were unable to attend to the number of calls that have been happening. The government took more initiatives. Now the quit line numbers are displayed on every tobacco product that we are using. So the tobacco product itself is promoting that you can quit by calling on this number. So it is important that there is adequate evidence that quitting is possible with the help of such strategies, but it needs to be promoted. People need to be made aware that these numbers are where they can call and get support. Okay, so there is enough adequate evidence which talks about mobile based messaging. I will be talking about M cessation strategy following this. This was the M cessation strategy which government of India actually implemented. You need to give a missed call to this number, and once you give a missed call, this particular the automated messages start coming, whether in Hindi, English, and now they are diversified into different languages. The government of India is also working on integrating the M cessation with the quit line. Those people who are actually missing out because of the overburdened quit line system would be connected to the M cessation team, and automatically they would get messages, and they could be scheduled later for a call. So M cessation has been promoted a lot by WHO. Be healthy, be mobile. The concept came into existence way back, and they have been promoting mobile health interventions in various health conditions, and as well as very strategically designed these interventions are there. And it has seen that almost 4% of people who have been attending to or using this M cessation have quit the habit at the end of it. The government of India is now developing the M cessation SMS strategies in 12 languages, and they intend to target more and more number of patients, users at the end of this whole thing. So India has launched the various interventions like M diabetes through various programs like the Ayushman Bharat, and even the TB control program has the mobile intervention in place. So So you can see that use of technology is one of an, I would say, a path breaker when it comes to reaching out to the masses who do not know where to go. The WHO also came up with something called as Quit Text, which is again an automated kind of a chat bot, which mainly uses WhatsApp to chat with the tobacco user. They have recently launched the M Yoga and also the M NCD, which is mainly for NCD prevention. So there are many such interventions which are already in place. The only thing is the promotion and the outreach of these interventions is important. So recently, during this World No Tobacco Day, they launched the artificial intelligence, digital health worker who's based out of AI, and Florence is her name. She basically would interact to you as a counselor. Mainly in the Western countries, have been used in some African countries, but this is something which is going to be a reality in times to come. Pictorial health warnings, we are all aware of it. Government of India implemented the 85% pictorial health warnings, and main issue was these pictures weren't of that good quality, and certain images were blurred out. But now the government is very categorically working on how exactly the quality of the pictures and what standardized content and the standardized placement of these pictures would have a huge impact on end users. But still, there are lot has to be done with this. Now the national quit line also has been displayed on this. A newer concept which has been promoted under the National Health Mission is tobacco free villages. Many states across the country have been successful in actually implementing tobacco free villages, whether it is Punjab, whether Andhra Pradesh, whether it's Jharkhand, and many states have been successful in doing that. So what they do in the whole process is, they have a very strategic approach. They go about first sensitizing the panchayat, the sarpanch, and the members of the panchayat. Then after that, they involve certain community members. Following that, they start implementing certain tobacco control measures of displays of tobacco free villages, as well as signages of where not to use tobacco, and advertisements, banning certain advertisements and displays. And as a result of which, they also incentivize villages by providing them financial incentives as well as other incentives, which actually motivates them to do and achieve these targets. So these are kind of success stories which are there, and these are the various criteria for tobacco free villages now being implemented through the National Health Mission. So this is again another intervention. I think one of the speakers did speak about I would say she spoke about pregnancy and women. So we are all aware that the women main issues is that the men are consuming more amount of tobacco, whereas the women mainly consume SLT, the smokeless form of tobacco. But their reasons for their consumptions are very varied. So it is very important that gender sensitive cessation strategies are developed. This is going to be the norm if you're really going to help them to quit and come out of this habit, because we all know tobacco is addictive. We all know that this particular group has certain social issues, as well as, I would say, personal issues, and it needs to be targeted in that manner. So strategies wherein they feel more comfortable, where they're able to contribute, where they're able to share their problems, as well as it should be culture sensitive. Such kind of strategies need to be developed, though there are a lot of examples of that. For example, the Project Mukti, which was one of the very intensive healthcare provider based, as in mainly Asha, a health worker provider based intervention, wherein Ashas were responsible for counseling and motivating women who were tobacco users, and it was very successful strategy. So similarly, you can organize health programs. For example, you can have role plays, you can have self-help groups, and similar strategies with the being more gender sensitive. So this is something which we have to keep in mind when it comes to a particular gender based. Workplace based cessation is also very important, because it is what happens is, many of the workplaces are actually they promote more of stress. So it is very important to understand the working conditions, and at the same time also provide work-based cessation strategies. A lot of studies have been done, but in Indian context, not much has been done. One of the studies by Gaurav Mishra from Tata Memorial Hospital reported that it was actually important to have more amount of open discussions to discuss these issues, and to bring it out as a part of the recruitment process, to bring it out as a part of the annual medical checkup in case if it is there, and bring it out in routine programs that have been discussed. So that would actually enhance, reduce the stigma and promote cessation. So then that I already told you about the global youth tobacco survey. This was recently released. Though there has been a 42% decrease in the tobacco use among youth, it is still the prevalence still remains high among both boys and girls. And it is important that our cessation strategies, our tobacco control strategies continue to work in these lines, so that we need to catch them young and see to it that they don't fall trap to the tobacco industry tactics that they have been trying to influence these children by providing them different incentives and promotional campaigns. There is a huge scope with national health programs. We are aware that there is a huge list of national health programs. Every program has adequate, I would say, scope for integration of tobacco cessation, whether it is elderly care, whether it is maternal child care, whether it is NPCDCS, the cancer, diabetes, and stroke program, whether it is a TB control program or TB elimination program. Every program has certain scope of integrating and reaching out to the masses wherever it is possible. Okay, so I would not go into details of that. So other than that, there are professional organizations who could actually contribute. There is IDA when it comes to dental context, the Indian Dental Association, the Indian Association of Public Health Dentistry, who has been in the forefront of developing and establishing 300 plus tobacco cessation clinics with the support of Dental Council of India, along with the Ministry of Health and Family Welfare across the country. So that is itself showing that these people, these organizations can spearhead and bring about a lot of change if they really desire. So it is important. Other than that, there are a lot of non-government organizations also who have been working. For example, the Balaji Seva Sansthan working in Uttarakhand worked towards, with the government of Uttarakhand, made Tambaku Mukt Mahakumbh. Similarly, there's Salam Bombay Foundation, which works in Mumbai and does a huge lot of work when it comes to targeting the community base and promoting tobacco cessation. Voice of Tobacco Victims is a cancer patient affected group, which themselves are who go out to interact with everyone and provide share their sufferings, as well as make it more visible to people that what happens when you ultimately suffer from cancer, because most of them do not believe this. This is something which we had started in our institution, wherein all patients walking into the hospital were screened, motivated, and directed to tobacco cessation clinic for promoting tobacco-free hospitals. So the security guards were trained, and on a daily basis, they would collect the tobacco products, and ultimately we would dispose them. So, COVID has been a huge opportunity, I would say, when it comes to such preventive and the promotion of such preventive. We have been instrumental in developing and providing telephonic support to these patients in a very strategic manner. Those patients who are tobacco users could connect with us and could get telephone-based counseling through this strategy. Other than that, there's a lot of IEC material. There's a lot of available resources which have been utilized by various state governments as well as the government of India, and is available for utilization and generating awareness among. You must have seen Mukesh. This is Mukesh. His story, and it has been had been promoted before every movie. They had promoted how cancer affects and tobacco affects individuals. So you making use of health education material, which is very simple, which is very targeted to certain groups and to certain situations, would actually have more impact. So creating such would also be useful. And we all know that electronic cigarettes has been banned in our country, but it is important that in case if anywhere such products have been sold, it is important to be brought to the notice of the necessary people. So Ayushman Bharat is coming up with health and wellness centers, almost 1.5 lakh health and wellness centers across the country. There's a mid-level healthcare provider who's also going to be trained, and this cessation service would be available through these health and wellness centers also. So in case if you really want to look into how to plan, execute, utilize different strategies for community-based health tobacco cessation, these are certain resources that are available for yourself, and you can review them. But every intervention does not go without challenges. It is important that a comprehensive plan is developed, but many of these programs do not plan and work on those lines. So there's a lot of coordination which is required between agencies, and that is where we lack and we need to work towards. A lot of motivation is needed to deliver cessation, because it is not a one-time solution. It needs to be reinforced repeatedly, and at the same time, at the grassroots level, implementation always is a challenge because of shortage of funds as well as human resources. So every intervention needs to be looked through a lens of monitoring as well as evaluation. Until and unless all the steps are not fulfilled and are not, they do not meet the objectives, we cannot actually support such evidence. So it is important that when you plan such programs, you need to understand that develop contextual based, tailor made, comprehensive packages for community level programs, involve people from the community, whether they're leaders, representatives, healthcare providers. We all know that tobacco is a major risk factor, but it is important that when you make it patient centric, when you make it community centric, when you make it disease specific, at the same time it is culturally sensitive. Implementation of these strategies will surely work. So with these lines, I would like to conclude my presentation, and I thank you for your honest, and I know I've exceeded my time. Thank you for your patience, and this is the team from the National Resource Center at our institute.
Thank you, Dr. Sachidan. Thank you, Dr. Mohanty, for the wonderful talk.
Okay, I will take this opportunity to introduce our next speaker, Dr. Jagdish Kaur. He's presently the Regional Advisor, Tobacco Free Initiative at WHO, Regional Office for Southeast Asia. And ma'am is trained in global tobacco control from Johns Hopkins Bloomberg School of Public Health, USA, with extensive experience in tobacco control and non-communicable diseases control in India and at global level. Before joining WHO, Dr. Kaur worked with Ministry of Health, Government of India, where she spearheaded development and implementation of several national health programs and was part of various high-level committees of the government. She steered publication of several documents, reports, modules, guidance, material for the Ministry and WHO. And she has published several research papers in national and international journals. And while the talk of Dr. Mohanty was going on, we have already seen that Madam has already replied so many queries on the chat box. I will request Dr. Jagdish Kaur to start her presentation.
Thank you so much for that very generous introduction. Good evening, everybody. Namaskar. I'll just share my screen. Is someone from your side sharing the screen? I'd shared my presentation. Okay, thank you so much. This is helpful. Okay, we can go to the next one. I'm talking on progress on tobacco control in Southeast Asia, and I'll try to do justice to this presentation in 20 minutes allotted to me. Next, please. So WHO Southeast Asia region comprises of 11 countries, and you can see this in this map, these 11 countries, and the one which is far away is North Korea. This is part of this region, surprisingly, but that is how it is. And we host 1/4 of the world's population. 26% of the world's population, they reside in this Southeast Asia region. Next, please. So all the countries of the region except Indonesia, they are parties to the WHO FCTC. Dr. Mohanty briefly mentioned WHO Framework Convention on Tobacco Control. So this is the only treaty WHO has entered into in its entire history. Why? Because tobacco is a global issue, and the tobacco companies, the big tobacco companies, they have multi-country presence. So they are international global companies, and then we need strong partners, strong networks to deal with tobacco control globally. Next, please. So WHO Framework Convention on Tobacco Control, it has various parts. The part 2 is the objective guiding principles and general obligations of the treaty. Then part 3, these are the measures relating to reduction of demand for tobacco. So it is very important to work in a balanced way to reduce the demand as well as the supply of tobacco. So under the demand, basically we have price and tax measures to reduce the demand, like increasing the price and tax of tobacco products. Then there are non-price measures, Article 7, then there Article 8 is protection from exposure to tobacco smoke, that is secondhand smoke. Then there is 9, regulation of contents of tobacco products. 10 is regulation of tobacco product disclosures. Like we write what all is there in this pack, whether it is of cigarette or any other product. Then packaging and labeling of tobacco products, this graphic health warnings which are there, that is Article 11. Then Article 12 is education, communication, training and public awareness. These are the campaigns, various activities we do under this. Article 13 is tobacco advertising, promotion and sponsorship. We call it TAPS. And Article 14, which Dr. Mohanty talked about, is demand reduction measures concerning tobacco dependence treatment. Next, please. Then there are measures relating to reduction of supply. But basically, most of the time countries are focusing on reduction in demand. So there is an imbalance. We need to focus very seriously on reduction of supply so that a balance is there and we actually kind of achieve effective tobacco control. So Article 15 is illicit trade in tobacco products. And Article 16 is sales to and sales by minors. Article 17 is provision of support for economically viable alternative activities to tobacco growers and tobacco manufacturers. So these are 15, 16, 17. These are very important from the supply reduction perspective. Then there is protection of the environment, because we know, that is an entire area where we talk about effects of tobacco on environment, from different perspectives, and we have a good publication by WHO also, and that is Article 18, protection of the environment and the health of the persons. Article 19 is liability, and that is in the part 6. Then there is part 7. There are articles related to research, surveillance, and exchange of information. 20, reporting and exchange of information. 21, then cooperation in the scientific, technical, and legal fields related to various expertise. So these are the different articles which form the treaty. So it's a very comprehensive treaty, and like I said that Southeast Asia region is home to about 1/4 of the world's population, and we house 230 million adult smokers and 248 million adult smokeless tobacco users, and that amounts to 20% of global smokers and more than 80% of global smokeless tobacco consumers. So this is the region, including India, which consumes smokeless tobacco. So it is always tobacco cessation for us. It is not smoking cessation. So I was just wondering at this, smoking cessation, why it was taken, because it is tobacco. And the diverse population groups across the 11 SEER countries, and some have high socio-cultural acceptance for the smokeless tobacco products, especially the ones which are used along with the betel nut. So they are socially, culturally acceptable, and they're a norm. So it is very difficult to bring out these products from the socio-cultural milieu. And we have Thailand and Maldives as upper middle income countries, rest are lower middle income countries. So there is huge economic burden of tobacco in the region, along with the health burden. So it has social burden, economic burden, environmental burden, along with the health burden. So effective tobacco control is of utmost significance for the region. And because if we are able to control tobacco in this region, then it has global significance. We cannot achieve global tobacco control without having achieved tobacco control in the Southeast Asia region, and also the targets, the global targets which we have for the NCD action plan to be achieved by 2025, and also the SDGs by 2030, because a lot depends on tobacco control. This is a major risk factor for most of the main NCDs. Next, please. So current tobacco use among adults. So as per the latest surveys which we have, so I have shown here, the smoking blue bars and smokeless tobacco red bars. So if you look at smoking, we have countries like Indonesia, Timor-Leste, and they are the countries where smoking products are used. And Indonesia is a country where they use critics, which are club cigarettes. They are flavored with clubs and traditionally used, and they are machine made also and homemade also, and this is the most prevalent product there. And then we have Myanmar. They have very high prevalence of smokeless tobacco. Then we have smokeless tobacco in Bangladesh, India, now also in Nepal, Sri Lanka. They are coming up with this. And DPR Korea doesn't report of any smokeless tobacco. They say that it's kind of they have only a smoking problem, and they say that it's only among men. They don't report any data related to women. Next, please. So this is among the youth. This is based on basically global youth tobacco survey, which is the standard one. We look at tobacco use among school-going students, 13 to 15 years old, and they're also, like, India just released the report of their latest GYTS 2019. And in fact, in 2019, many of the countries, they went for GYTS in my region. It's the Bhutan went, Indonesia, and then we had Maldives, we had India also, Sri Lanka also. So these are the countries. And why Maldives is showing 46.1%? Because they included these pan masala and other things also. So it is not smokeless tobacco, it includes the betel nut products also. Otherwise, it's not like that. So this is the latest one showing that. Next, please. So trends of current tobacco smoking among adults, it's because the trends report had taken only smoking into consideration, because we didn't have enough data points to show the trends for smokeless tobacco, because some of the countries who are having a high prevalence of smokeless tobacco use, they did not consider when they were doing their surveys, they did not capture that smokeless tobacco. So but now in the next trends we are trying to capture that. So as per this, slowly it's coming down in most of the countries except Indonesia. Indonesia is a real issue, because one is that they have a very high prevalence among the adults as well as the youth, and they are not party to the convention, and there is extensive tobacco industry interference. So that is a cause of concern globally. Next, please. So like I'm showing a couple of countries here, just comparing some indicators, GATS1 and GATS2, both India and Bangladesh, they did first global adult tobacco survey in 2009-10, and they repeated in 16-17. India is now also preparing for the third round of GATS. So prevalence of current tobacco use as per GATS, it declined. So earlier we had more than 2/3 of population using tobacco, and now it is a little more than 1/4. So there is a decline among smokers, among smokeless tobacco users. That's a good thing. So we also had a reduction in exposure to smokeless tobacco use at home, but not much at the workplace, and almost same in the healthcare facilities, which is a little disturbing. Next. So quit attempts among smokers in the past 12 months, which we capture here by the age group, so almost similar. The quit attempts didn't in this period, between 2009-10 to 2016-17, there was not much of difference, but there was a difference in this young age group, 15 to 24. So that is a good thing. And people who noticed health warning labels on packages of cigarettes, bidi, and smokeless tobacco, because as per Indian law, the warnings have to be, all the tobacco products. So that increased. So people noticed on cigarettes, bidi, as well as smokeless tobacco packs. Next, please. So people who noticed any type of cigarette, bidi, and smokeless tobacco promotion, as per GATS India. So somehow, it declined. So that means the enforcement was better as per the survey, and on all the products. And average monthly expenditure on cigarettes and bidi as per GATS India, so it was more. Next. So now if we talk about Bangladesh, so prevalence of current tobacco use by gender and residents. So here we are talking about, both the GATS 2009-10 and 16-17, and there also there was an overall decline in tobacco use among the males, among the females, and in the urban as well as rural areas. So that's a good sign, because India, the region has three big countries. Besides India, we have Indonesia and Bangladesh as per population. So these are the three countries who contribute to all these indicators in a big way. And exposure to second-hand smoke. So Bangladesh was better, because there was a decline in home, in restaurants, workplaces, public transportation, government buildings, and healthcare facilities. So as compared to India, they are showing this indicator in a better way. Next. So quit attempts and advice to quit by healthcare provider among current tobacco smokers who visited in the past 12 months by residents. So we are looking at urban and overall at the rural. So kind of, quit attempts little lower or similar. I mean, difference in the urban areas is more as compared to rural, and it's showing a decline in the quit attempts. And then advice to quit by healthcare provider to the people who are using tobacco. This was more, so significantly increased overall as well as urban and rural areas. And people who noticed and thought of quitting because of health warning labels and noticing anti-tobacco information at any media or location among current tobacco users. So there was an increase as compared to this, and significant increase by looking at smokeless tobacco packages, because Bangladesh also has, I mean, from 0.1 it went to 53 point, almost 54%. That's quite significant. On BD packages from 48.6 to almost 84%. So that's quite significant. So this is for Bangladesh. Next, please. Noticed any pro-tobacco advertisement, sponsorship or promotion in the media or location in the past? So that declined for cigarettes. There was an increase for BD and smokeless tobacco in Bangladesh if we compare to that. And average cost of 20 manufactured cigarettes, BDs and monthly expenditure in Bangladeshi taka BDT. So cost of 20 manufactured cigarettes, it was more, and expenditure on monthly expenditure on cigarettes was more. Cost of BD, I mean, from 11.1 to 16.5, and BD monthly expenditure also rose. But there's one thing that although Bangladesh has higher taxes on tobacco products, but I mean, nearly 70% it says, but even then, all the tobacco products, they're very, very accessible. They're very cheap. Smokeless tobacco and BDs and cigarettes, plain cigarettes, so at very cheap rates. So they are very, very accessible. Next, please. So if we look at this selected indicators of tobacco use over different rounds of GYTS in India. So India conducted 4 rounds in total, and this round has been conducted after 10 years. The last one, when I was there in 2009, and after that it is 2019. So there is significant decline among the youth and then the girls, boys, cigarette smokers, and BD smokers, and in fact, the source almost remains in the opening cigarette store, and I mean, these are the indicators, and we are seeing decline among youth, and that is a good sign. Next, please. So if we look at Bhutan, Bhutan has undertaken 3 rounds of GYTS, 2009, 13, and 19. That is, I mean, in the last 10 years, 3 rounds. So the first and second, there was a steep increase, and then third round, it saw a steep decline. So that is where Bhutan is. Next, please. So prevalence of current smokeless tobacco use, similar trend. I mean, it just went up and then came down, but not to that level as it was in GYTS. Bhutan has high prevalence of smokeless tobacco use, and also the betel nut. I mean, everybody over there just uses betel nut, including the small children. Next one. So Maldives, like I said, this steep decline, because this question was, on the betel nut use, flavored betel nut and pan masala, other things, whatever they were consuming was same. So, it is showing the sharp increase. Next, please. Maldives, the same thing, it's showing here because of the that question. So this is the smokeless tobacco slide. Next, please. So Timor-Leste, they have done, we are comparing here 2 rounds, GYTS 2013 and 2019. Timor-Leste also, it's a high tobacco use prevalence. This is a country, small country, just next to Indonesia. So basically, most of they don't manufacture anything, but mostly it comes from Indonesia. And it's a very new country, newly founded also just at the turn of the century, and they came up with their tobacco control law in 2016, but they are a country who are implementing the largest size of tobacco warnings in the world, entire world, 92.5%. So there they showed a decline in smoking. So overall tobacco use was less among children, then current tobacco smokers was declined, but smokeless tobacco. So just notice that, see, these are the things which is happening. So even if we are in some countries showing, if they are showing decline in smoking, so there's nothing to be happy about that, because we have to look at other products, which is an industry tactic. Next. So monitor, like Vikrant mentioned about this WHO Empower, it's a package, technical package, which consists of six strategies: monitor, protect, offer. O of this is, it kind of relates to cessation. So monitor is you are monitoring tobacco use and prevention policies. Protect is protect from tobacco smoke, that is secondhand smoke. Offer, help to quit, and that is cessation. Warn is warn about the dangers of tobacco. So that can be through the media campaigns, and that can be through the graphic health warnings. And enforce bans on taps, tobacco advertising, promotion and sponsorship. Raise taxes on tobacco. So these are the 6 policies. So we publish every 2 years global tobacco control report based on, we monitor these 6 policies implementation, and these are basically demand reduction. Like I said, there is most of the focus is on demand reduction. So WHO monitors that, and first report was published in 2008, and the last one, the latest one is 2021, which published, and we looked at what has been achieved during this period also at that. And this report focused at ends, electronic cigarettes and related products. So people who are interested can download this from the net or from the WHO website. Next, please. So here, we are just showing in this slide that monitoring tobacco use. Incidentally, Southeast Asia region has measurable trends in tobacco use for 99.9% of its regional population. So, it's almost 100%. So we are very good at monitoring. That's a good thing. So this is highest among all the 6 WHO regions. So SARE is doing best in monitoring. But the number of countries who have achieved this highest level, who are doing the periodic surveys every 3 to 5 years at regular intervals, but they have to be both among adults as well as the youth. Like India, they didn't do this GYTF, so they didn't get, they were at a lower percent. So they are not among these 5, they are not here. So India is not there, but now they will be next GTCR, they will be put here. So I'll have 6 countries here instead of 5, if some country also catches up with that. Next, please. So next is on the policies on smoke-free environment. So we have only 2 countries, Nepal and Thailand, who are at the highest level of achieving, they are enforcing their smoke-free policies at the highest level, and they have been, since 2017. Earlier it was Bhutan also, but then they backed out, and then now it's Nepal and Thailand since 2017, then 19 and 21. But India, because there are gaps in their, smoke-free policies, so they are not showing it. So India has 1 or more public places, where designated smoking rooms are allowed at airports, and if, it's this thing, a restaurant with more than 30 seating capacity or a hotel with more than 30 rooms. So their designated smoking rooms are allowed. So that is the thing why India cannot be here. So Bhutan and DPR Korea, they need to cover only 1 more place. Like if they cover cafes, pubs and bars and government facilities, then, they will join the exclusive list and they will come up in this part. Next, please. And now if we are talking of treatment of tobacco dependence, then India is the only country, which has achieved the highest level here, and they have been there since 2017. So before that, it was 0, and before that it was Thailand, but then there were issues with them, so it dropped. So we need to do a lot more in tobacco cessation in this region. So there are some countries, which have high prevalence of tobacco use, but they have not done anything on cessation. For example, Bangladesh, there is nothing much. Indonesia, they have a quit line, but not that much of functional. And Timor-Leste, just now we have started a quit line there, and also established tobacco cessation clinics, with all the 3 levels of WHO worked and pushed, and also provided them NRT donated by CIPLA. So 2 countries we provided NRTs, India, which is being distributed through IDA. We have selected some states. And in fact, CRO is in a collaborative agreement with IDA. So they are working on some things, to support cessation with us, training of health professionals and other things. So, but then Bhutan, like they don't have much. So they also started NRT campaign last year during the lockdown. So slowly and slowly they are coming, but there is a lot to do because this is, offer to help, but I always call it an orphan. Next, please. So if we look at the health warning for tobacco packages, then, I have 6 countries in this round, and the next one, the previous one, 2019. So, but then otherwise the region, except DPR Korea, which is the only country in the region which is implementing this text warning still. They don't have the graphic warnings, but other countries are implementing, every country, 10 countries are implementing, but then Indonesia has 40% of it. And then there are some issues like they're not rotating or other things. So countries who are meeting all the criteria, who are at the highest level of achievement are 6. But we are a region who are implementing the largest size of warnings. Like I said, Timor-Leste is 90.25%. Then we have Nepal with 90%. We have, India with 85%. We have Sri Lanka 80%. So the country is, implementing that. And then on all tobacco products. So that's a good thing. Next, please. And if you look at anti-tobacco mass media campaigns, only Indonesia, Myanmar, Thailand, and Timor-Leste, they are fulfilling this. And in fact, in the last round, also Indonesia, Myanmar, Timor-Leste, they were there. India is not featuring here because, they were there till 2015, because then they were having regular campaigns. They were meeting the criteria of highest achievement, but now they are not there. Next, please. This is showing ban on tabs. Like I said, it's only 2 countries, Maldives and Nepal. So they have been there from 2015. In fact, Maldives was there from in 2013 also. That time it was the only country, but now only 2 countries are there who are implementing and forcing bans on tabs seriously, and they are at the highest level. Next, please. Now, tobacco specific taxes. Here also, unfortunately, only 2 countries, Sri Lanka and Thailand. Bangladesh was there earlier, but now, it has come down. So we are looking at least 75% of the share of tobacco specific taxes in retail price of the most widely sold brand of cigarettes. So if you are over the mark of 75%, then only you are part of this elite club. So only Sri Lanka and Thailand are meeting the criteria. And other countries, they have been inconsistent in their efforts, and most of the tobacco industry interference, that is at this level. They don't want the taxes to be high, and that includes India also. Next, please. And then we come to now supply side. So Article 16 of WHO FCTC. So this aims at restricting access and supply of tobacco to adolescents and requires parties to adopt and implement measures to prohibit the sale of tobacco products to and by minors, as well as other measures limiting the access of underage persons. So different countries have different age criteria. And in DPR Korea, North Korea, you can't buy, you can buy if you are 16 years. And Timor-Leste, 17 years. But most of the countries have 18 years, like India. So Bangladesh, Bhutan, India, Indonesia, Maldives, Myanmar, Nepal, you have to be at least 18 years of age to buy tobacco. Thailand has put it at 20. They just raised a couple of years back. And Sri Lanka is the only country which has this age of 21 years. Next, please. So we are also a tobacco producing region. India is one of the largest producers, second largest in the world, and then Indonesia is the 6th largest, and Bangladesh follows. Then DPR Korea also, Thailand produces, Myanmar also, Sri Lanka a little bit. They only have 3,000 farmers in Sri Lanka. So these are the India and Indonesia, and then followed by Bangladesh. These are the major countries who are producing tobacco. So we have to reduce that also. You have to reduce the supply of tobacco over a period of time, and that is as per Article 17 of WHO FCTC. Next, please. So India has also started a program with Ministry of Labor, where they are providing the skill-based training to women who are BD rulers, and they are. This is under the National Skill Development Corporation scheme, and they have moved already. WHO India office is supporting this. Some women, from the BD rolling to other professions, and that's a good thing, which the government is doing in both Ministry of Health in partnership with Ministry of Labor. Next, please. So if we talk about economically viable alternative crops, so this FCV, so there are two main types of tobacco. FCV is flue-cured Virginia tobacco, which is used to make cigarettes. And there is non-FCV, which is used to make the smokeless tobacco, BDs and other things. So FCV is highly profitable, and that is why government depends on this revenue, and we have entire tobacco board and which Ministry of Commerce looks after. So, but I mean, as per research, we have now seen that if we follow some, because FCV cannot be replaced by a single crop, it is not that much profitable. So, but if you follow some cropping pattern, hybrid, cotton, chili, groundnut, whatever things, so you can have those. There are other things also, but these are very rich farmers supported by the government and all that. So even there are, I mean, they have done research in like this Prakasam district, Andhra Pradesh. It's a big district growing tobacco. So they are already giving up growing tobacco because now the production cost is high, and then there is this lot of noise about tobacco control. Entire program, National Tobacco Control Program, is running, and so various things. So also depends when we are reducing the demand. So when there is reduction in demand, then there is this thing happening that on their own they are shifting, and that happened in Sri Lanka also. So Sri Lanka government, they announced that they will shift all their 3,000 farmers. Ceylon Tobacco, they have their own company. So they said that we will shift all our 3,000 farmers, but I mean their target was 2020. They have missed on that target. There was change of government. So their kind of commitment and all declined, but I mean, they are doing better. Next, please. So this protocol, another thing for supply reduction is the elimination of illicit trade in tobacco. So we have a protocol, and then there are parties to this protocol also. Like we have conference of the parties, all the 181 countries which are, who have ratified the WHO FCTC, they are members of the COP. They are parties to COP. And similarly, more than 40 countries, I think now 48 or what, they are parties to MOP, meeting of the parties, who are members of this protocol, who have ratified this. So in my region, only India and Sri Lanka. Sri Lanka had done it first, then India followed. So they are only parties to this protocol. But this region, like India, Bhutan, Nepal, Myanmar, Bangladesh, they share borders, and then some are close, like Sri Lanka, Maldives. So a lot of illicit trade is happening. So these countries, they should all ratify this protocol, and they should all work together for this illicit trade, because that's the big thing which is happening. Because most of the countries, small countries who are not producing tobacco on their own, they get this illicit tobacco, at very low rates. So that is what, so it beats the taxes. Next, please. And then we come to electronic cigarette ends. So these are the, under the category of new and emerging tobacco and nicotine products. Fortunately, we don't have that much of this problem of heated tobacco products, which we call HTPs. So which are there, in now Japan, South Korea. I mean, it's just coming that way from that side, which industry is bringing to replace the smoking the cigarettes. So in my region, DPR, Korea, India, Nepal, Sri Lanka, Thailand, Timor-Leste, they ban the sale of e-cigarettes, and Maldives, they regulate them, as tobacco products. So we have a number of countries who have taken steps about these products. And this TPR, Korea, India, and Timor-Leste, they are among the 11 countries of the world who have completely banned. So it is the ban of sale and ban that restricts their availability of the heated tobacco products also. So ends plus HTPs. So the countries have taken proactive steps because these products are being introduced by the industry. Next, please. Now, if we come to tobacco industry interference, this is this region, and in fact, globally also, tobacco industry, they are very, very, very influential, very, very powerful people, these big multinational countries. And that is why I said that the treaty came into being. So they are at the highest level of policy making. They are everywhere. So I have Bangladesh, Indonesia, India, Bangladesh is the highest. If we had a score, on a scale of 100. So we mired this tobacco industry interference. So there's lots of this. Timor-Leste, that's a small country and they don't manufacture anything. So they had the lowest. Nepal, they also don't manufacture anything. Thailand have a big issue, of this, and they even are trying to roll back this ban on electronic cigarettes. So industry always tries that. So and this was, lots of tobacco industry interference in the garb of CSR, was seen during the COVID-19 pandemic. So, the industry gave cash, then COVID-19 supplies, ventilators, other things to different governments, and India also, they contributed to Prime Minister's fund also. So, this has to be pointed out by various agencies, especially the civil society organizations who are working this. And there are so many other sources to get funds. You don't need to take money from tobacco industry. And in fact, in Bangladesh, they came up with a very old act, and they said that this is under the essential supplies cigarettes, and you please allow us to continue that. And that was by the Ministry of Industry, and Ministry of Health was very helpless. So these are the tactics which, they come, and there is Article 5.3 of WHO FCTC, which talks about this, and that is the least implemented. And I think government should make more efforts for this implementation of Article 5.3 in black and white. But till the time we have the same issue we have here, Ministry of Commerce, this tobacco board, that is industry supporting the crop and other things, and saying that we get money from, revenue from exporting the cigarettes and other things. Same is, government officers, they are members of this board, and same is with Bangladesh. So these two big countries are having a lot of interference. Indonesia also, they all the time talk to the president and all. They don't let anything happen. They don't let Tobacco Control Act, law, get implemented and enforced. Next, please. So we have this issue of tobacco product regulations. So it is very important to test, to test tobacco products and see what is there inside these products and how harmful they are, so that you bring in your public health evidence. So the region didn't have labs. Indonesia was the only country which had a lab, but not that much of functional. So India established in 2018, the labs were functional, 3 labs, government labs, which are established, and we at the regional office, we are supporting lab at Nimhans, their toxicology lab, and now they are testing smokeless tobacco for their flavors. So first time, we focused on testing the flavors, and we are also part of this global mechanism to standardize and validate the methods for smokeless tobacco, because see, no other region would do it. Only we are a region with problem of this. So we only had the standard methods to test cigarettes, and nobody was talking about, even I can recall 10, 12 years when we used to go to this FCTC meetings and other global meetings, nobody would talk about smokeless tobacco. Now at least they are talking, because now it has reached beyond the region and almost 150 countries, and it has become an issue. So now testing smokeless tobacco, so validation of those standard methods are the things we are doing, and NIMAS is also participating. And last year, we made all these 4 labs members of the WHO Top Lab Net, which is a network of almost 50 labs globally who are, testing tobacco products. So now region also is on that map. And law mandates display of qualitative information on relevant constituents and emissions of tobacco products on tobacco packs in DPR, Korea, Myanmar, Nepal, and Thailand. So only 4 countries, they are mandating that, we should be telling, how much is the star, how much is carbon monoxide, how much is nicotine in this pack of cigarettes. So 4 of the countries are taking those first steps. Next, please.
Respected ma'am, I'm sorry for interruption, but we are really running late.
So that is the last slide.
Okay, that's good. that was so kind.
I think I did justice in 20 minutes.
Yeah,
Thank you so much.
Excellently did.
Thank you. Thank you so much.
Thank you so much, ma'am, for your excellent talk. So,
Dr. Kaur, can I ask a quick question? Your presentation showed that India is the biggest producer of tobacco, while
no, that is in the region.
In the region, because my understanding was China
is the biggest.
China is top 5 producers put together.
Yeah. China is, that is in the region. I was talking about the Southeast Asia region.
Okay, okay, thank you.
Thank you.
Okay, thank you, ma'am, for answering the question. Since we are running out of time, so I thank all the other speakers, and I thank Dr. Sachidanand Bharti also, my co-chairperson. And now I hand over the stage to our coordinators. Thank you.
Thank you. Thank you.
Thank you.
Thank you, Chairperson. So with this three beautiful lecture, and due to paucity of time, this is the end of session 6, and I now request Dr. Harpreet to start session 7. Dr. Harpreet.
Thank you, Dr. Kunal. Good evening, everyone. I thank each and every one of you for joining us today. Now we are kicking off the session 7, but before the session, it's my pleasure to introduce you with the chairpersons of session number 7. Our first chairperson is Dr. D.N. Sharma, who is the professor and head of Department of Radiation Oncology at Dr. B.R. Ambedkar IRCH and National Cancer Institute of AIIMS, New Delhi. Dr. D.N. Sharma is well known around the globe for his influential work in the field of interstitial brachytherapy and intraoperative brachytherapy. He has done fellowship from Ohio State University, University of Kentucky, and MD Anderson Cancer Center. He has been awarded with AIIMS Research Excellence Award in 2014 under clinical category. Dr. D.N. Sharma has attended various national and international conferences as speaker and has been invited as faculty and speaker at American Brachytherapy Society annual meeting in 2015 and 19. And he has more than 240 publications in his name. Thank you very much, sir, for joining this conference.
Thank you.
Our second chairperson is Dr. M.N. Barua, who is the Managing Director of Northeast Cancer Hospital and Research Institute at Guwahati, Assam. He is the Chief of Head and Neck Oncology and Head of Research Division. Dr. M.N. Barua is actively associated with cancer research at molecular level with IIT Guwahati and is working against tobacco in rural Assam with Center for Health Education and Prevention. A warm welcome to you, sir, for joining.
Thank you. Yeah, thank you. Yeah.
Without taking much of your time, may I now request our chairpersons to take over the session. Thank you very much.
Thank you, Harpreet. It is nice to be here on the this conference. And on behalf of my co-chairperson, Dr. Barua, I welcome you all to this 7th session of the International Conference on the Tobacco Control, organized jointly by the Indian Society of Clinical Oncology and the Lady Hardinge Medical College. This session has 3 talks, and each talk is of 20 minutes duration. So I'll request all the speakers to stick in time. May I now first request Dr. Sonu Goyal to start his talk. Dr. Sonu Goyal is the professor of community medicine at PGI Chandigarh and is a well-known figure. So without wasting much time, I would request Dr. Sonu Goyal to start his presentation. Dr. Sonu, please.
Hello, good evening, friends. So today in this presentation, we'll be talking about tobacco use among healthcare professionals and the role of primary healthcare workers in tobacco cessation. I am Dr. Sonu Goyal, working as Professor of Health Management in Department of Community Medicine and School of Public Health, PGI Chandigarh. And I am also a co-chair of International Union Against TB and Lung Disease Tobacco Control Section. Most of you in the audience might be aware about this dreaded life cycle of tobacco. It starts from tobacco farming. You can see extreme left lower side to preparation of these tobacco products by the workers. You can see the BD workers who are rolling the BDs, and then you can see smokeless tobacco products. Then it is being sold in the market, and then it is being consumed. And on the lower down, you can see that the lung is distorted, it is black, charcoal. It is all due to the tobacco which a person inhales. As far as burden of tobacco control, tobacco use is concerned, globally, tobacco is the only legal product in this entire globe which kills half of its users. That means if 100 people take tobacco at a point of time, anywhere down the line, it kills 50 of those 100 people. 80% of the world's 1.3 billion tobacco users stay in low and middle income countries. And overall, 8 million people die due to tobacco use, that is 80 lakh people, out of which 7 lakh people die due to direct tobacco use, and 1.2 million innocent people die due to exposure of tobacco use that we call as second-hand smoking, or previously called as passive smoking. And if we, in economic terms, if we say 2.5 million disability adjusted life years are lost due to smokeless tobacco, and around 150 million disability adjusted life years are lost due to smoking. So this is the burden of tobacco use as far as the globe is concerned. If we say the various surveys which are being done, so these are the 4 prime surveys which are done globally. One is a global adult tobacco survey, which has been conducted twice till date, one in 2009 and 10, and one in 2016-17. Then there is a global youth tobacco survey, which has recently been done in 2019, and a report has recently been released 15 days back by Honorable Union Health Minister, Ministry of Health and Family Welfare. Then we have global school-based student health survey, GHSS. So this is another survey which is being done in the schools. And then there is a global health professional student survey, which is being done again globally. As far as India is concerned, the overall percentage based on the global adult tobacco survey, which recently been done in 2016, among the age group of 15 years and above, around 28.7% people use tobacco. So what does that comes in terms of figure? In terms of figure, that 28.7% comes out to be 26.7 crore adults out of the total 130 crores. That is, if it takes in terms of adults, so it's around 98 crore adults are there, out of which 26.7 crore use tobacco, in which we have a majority of smokeless tobacco users. That comes to be around 20 crores, and around 10 crores people are smokers, and 3 crore people use both smokeless and smoked form, that we call as dual users. If we consider like 13 to 14 years age group, which is being assessed by Global Youth Tobacco Survey, which I told that it has recently been released, which shows that around 8.5% of the youth aged 13 to 14 years use tobacco. Himachal, Karnataka, Goa, the prevalence is quite low. But if you see the northeast states, Mizoram, Arunachal, Nagaland, Meghalaya, Sikkim, so they have the highest prevalence of tobacco use among the youth. The silver line in both Global Youth Tobacco Survey and Global Adult Tobacco Survey, which has been done in 2019 and 2016 respectively, is there has been a decrease in tobacco use over a period of time. If you see the Global Youth Tobacco Survey, it was way ahead in terms of percentage, and which has been reduced to 8.5%. And as far as Global Adult Tobacco Survey is concerned, the percentage was initially 35% of the adult, which has been reduced to 28%. Now, the places of usual smoking which we see are home, school, at friends' houses. So these are the main places where this youth smoke. And the reasons for quitting, those who quit, is primarily to improve health. The lack of money also plays a role, but improving of health among youth plays a major role. And if we talk about the tobacco quit line, which I'll be talking later in the lecture, that very few people in youth have heard about this government initiative of tobacco quit line. Now coming to the topic, that is tobacco use among healthcare professionals, which has been assessed by Global Health Professions Student Survey. And it is being done in the third year students pursuing advanced degrees in dentistry, medicine, nursing, and pharmacy. And this is a questionnaire based on the self-administered questionnaire in the school, and the student anonymity was maintained throughout this process so that people come out openly whether they smoke or use tobacco. And these are some of the figures which we see that among the pharmacy, the percentage is quite high. It is 13% prevalence of tobacco use among students. Similarly, in the medical and dental, the prevalence is 11 to 9%. In nursing profession, the prevalence of tobacco use is quite low at 3.3%. And same is the current use of other tobacco products other than the smoking. You see that around 10% in the pharmacy smoke. That is the maximum among the medical professional students, and which reduced to around 4.5% in nursing and 5.4% in medical background. So this means that around like 5 to 13% of these medical professionals smoke or use tobacco. That is, again, we see quite high if we say the age group is 13 to 14 years. Then this is another data which we have got from that survey is there are a lot of questions which are being asked. I'll focus on these two questions which have been highlighted. That is, do health professionals serve as role models for these patients and public? So most of the people says that most of the dental, medical, nursing, and pharmacy background says that these health professionals serve as a role model for their patients and the public. This is their perception. And should health professionals receive specific training on cessation technique? Again, maximum of them, you can see 99% of the dental students said that they want to receive specific training on cessation techniques. And similarly for the medical background, nursing background, and the pharmacy background, the prevalence of those people who like them to be trained on cessation technique ranges from 83% to 91%. Now, why cessation is important? I think you all are from medical background, so you all know about some of the facts, but the main 4 important reasons are that tobacco cessation has a potential to provide the most immediate benefits of tobacco control. Like if there is a chart which is there, you might have seen that in 24 hours, your heart rate comes down, your pulse becomes normal. And similarly, you see the benefit right from the day one stops smoking. Although there are some withdrawal effects also, but there are some benefits which start from the day when person stops smoking, and then it comes to be around 5 years, 10 years. So the body organs comes to their own shape when you stop smoking at any age. Then second is it maximizes the benefit in terms of preventing disease, morbidity, and premature mortality, right? So it reduces the premature mortality due to tobacco use, and also a lot of morbidity which is due to like coughing and chest pain, and all those morbidity which are due to tobacco use are prevented by cessation. Then prevent a substantial proportion of complications for various diseases, like we can prevent various long-term complications from various non-communicable diseases, and also it provides not only health benefits but also social benefits and economical perks associated with quitting. So those people who are actually poor and those who are not able to afford their meals, So they spend almost 20 to 40% of their money, of their income on smoking. So if they quit smoking, so that is economical perks besides the healthcare cost which they have to levy due to smoking. Now, this graph, which is being taken from Global Adult Tobacco Survey 2016-17, shows that many people want to quit. Like you can see the question, current smokers who are planning to or were thinking about quitting. So it is around 55%. So out of all smokers who have been surveyed in this biggest, largest survey done in our country, 55%, almost half of them, more than half of them want to quit. And similarly is about the smokeless tobacco users. So again, it is around half of smokeless tobacco users want to quit. And again, it is almost similar for male and female. But this shows the other way around, that the participation by our healthcare providers is still suboptimal. You can see from the questions that smokers advised to quit by healthcare provider in past 12 months. So smokers were asked whether you were being advised to quit by healthcare providers. So it's only 50%. So it should be almost every healthcare provider should give them the advice to quit. So it is quite low. And similarly for the smokeless tobacco users, so they are not being either asked about the history of tobacco use when they come to the clinic, or they are not being advised. So it comes to be around 30%. So only out of 3 persons who are using smokeless tobacco, just 1/3 of them, 1 among 3, is being advised by the physicians. Now, this is a very important slide for all of us, because all of us are working in one or the other clinics. So why is our role more important than anybody else? The first thing is, this is, and the clinical, every clinical encounter of a patient is an opportunity to ask about tobacco use and offering support to them. So you might agree with me that if I go to a person's smoker's home and tell them that you can quit, so it is not that efficient or effective as compared to when a patient comes to you with some problem and you can relate that with the smoking or tobacco use, and you can use that as an opportunity, and that the person or the tobacco user or the patient listens more. So that is one. Second is addressing tobacco dependence by incorporating this as a part of their standard of care practice. You can always address this tobacco dependence and always keep this as a standard care practice in your routine clinics. Then it is a very important time, and if you educate the population on the harms of tobacco use, it is far, far more effective as compared to any lay person who is educating a person about harms of tobacco use. So your words are very important and effective. They initiate and support some of the tobacco control policy measures. So everybody knows about the law. In case you're not aware about, you should read about what is our law says, so we can support our tobacco control policy and law on that. Then last is add their voice and their weight to national and global tobacco control efforts like tax increases campaign. So you can add to their voice and you can show leadership and become a role model for the healthcare professional who are doing much more than what is desired from a healthcare professional by asking them and advising them about the tobacco control. Now, there are various approaches that can be used by you to promote cessation. The simplest one is the ABC approach. A means ask the person, whosoever comes to you in a clinic, make it a habit to ask them, him or her, about whether that person smokes or use tobacco. That's number one. Number two is, in case that person says that yes, he or she smokes or use tobacco, then give them the brief advice, and that brief advice to be tailored to that particular problem for which that person is coming. And C is, in case they are, in case they are not able to follow your advice, so you can provide or refer them for the cessation support. So this is A, B, and C. And cessation support are always present if you are working in a medical college. I think the Department of Psychiatry or Department of Community Medicine provide the cessation clinics. Now, this is another approach for those patients. I always say tobacco users as a patient because yes, for us, tobacco is a disease. So for those who are willing to quit, we should adopt the 5A approach. This is another approach which is a bit broader. Ask about tobacco use, then advise to quit. And at each visit, you should advise them to quit. Then keep on assessing the willingness to quit at each visit. Then assist them to quit within 2 weeks of the counseling. So keep on counseling them or send them to a counseling center and then arrange follow-up contact in first week of the quitting. So these are the 5 ways: ask, advise, assess, assist, and arrange. But for those patients who are tobacco users but not willing to quit, so we use 5R approach. We should inform them the relevance of quitting, why quitting is important, along with telling them the risk or the negative consequences of ongoing habit. Normally what I do is I always put some images, some cancerous images due to tobacco use in my phone. And I always show them that these are the problems which you might face if you keep on smoking or using tobacco. Then you should also tell them the benefits of cessation, the rewards in terms of economic benefit, like you can use that money for something else. You can, if you are healthy, you can play with your children. The children will not, no smell will come from your mouth, and so on and so forth. And then you should identify the roadblocks or the impediments to quitting. So that should be upfront, that you should tell the patient that, yes, these are the problems you might face when you are trying to quit, and then repeat every time when the patient comes. Relevance, risk, reward, roadblocks, and then again repeat all those things till they reach at the stage when the patient is willing to quit. And then you should go with 5A approach. These are the cessation support methods like behavioral therapy or the counseling, nicotine replacement therapy, and pharmacotherapy. Now, these are some of the techniques which can be used by a tobacco user. So it can be individual counseling when you are, you can call a tobacco user in case you are free. I know that you all are quite busy in your clinics, so you can send them to a counselor who can counsel not only the individual, but also the relatives of that particular patient. And I always prefer that whenever there is a counseling, always the patient should come with a family member or the close friend who can help or him or her about the benefits, or who can stay during that entire process of tobacco cessation. You can also send the text messages to the patients. Keep on. Group counseling should be followed with the text messages, and these things should be there. Then these are some of the IC material we have prepared. I think these IC material are very tailored approaches. My two PhDs are working on, one is in hospital setting and one is in health clinic settings in Ayushman Bharat Health and Wellness Centers. And we can always refer to the tobacco control centers, and there is a telephonic counseling can be done in the COVID time. So the mixed approach is quite effective if we want to use the counseling. And the counseling, why it is required is not everyone know that they can quit. People ask that quitting is very difficult. Yes, it is difficult, but not impossible. You can tell them that many people have quit and you can also quit. It allows you to explain the pros and cons of tobacco use, which a tobacco user might not know. They only know about the health reason, but they might not know about the social reason, the financial reason. It is cost effective and sustainable avenue as compared to the pharmacotherapy, and it helps to build the confidence in the tobacco users to quit. Somebody is with them and helping him or her about quitting, and it allows the tobacco user to share their hurdles and doubts. So these are the initiatives which are run by Government of India. One is National Tobacco Quit Line. I think you should remember this number, 1800112356, 1800112356. So this is the number which is there by Ministry of Health and Family Welfare. And this is telephonic counseling for those people who want to quit tobacco, and can be accessed from all teleservice providers, any teleservice provider. And right now, these are in 2 languages, English and Hindi, and they provide advice from 8 a.m. to 8 p.m., 6 days a week, except on Monday. So this is National Tobacco Quit Line. There is another program by Government of India, that is Cessation.
Please wind up, sir. We are running short of time, sir.
Patient can register by giving a missed call to this number 011 22901701. So this is the number. One can give a missed call to this number, and then you are registered automatically. Or this is the website in which you can register. And again, it is available on English and Hindi. What difference between the earlier program and this program is, it provides the evidence-based behavioral change text message on your mobile phone. So text messages keep on coming to you about health information on tobacco use, tips on quitting, and encouragement for those attempting to do so. So these are some of the programs which you can utilize besides the individual cessation at your own clinic. So towards the end, I just want to urge all of you to make your facility tobacco free. These signages of tobacco free facility should be displayed at your health facility, at your clinic, wherever you are. You should display the IC material and motivational posters which are there, and please place a box at the clinic entrance to drop all the tobacco products before entering the clinic. So I urge all of you to make not only make your facility tobacco free, but whenever any patient comes to you, make it a habit to ask him or her about tobacco use, give him the brief advice, and inform them about the cessation support which is present near them. So I thank all of you for the patient listening. Thank you very much.
Thank you very much, Dr. Sonu. Dr. Barua, sir, please introduce the next speaker.
Next speaker will be Dr. Just a minute. Now I want to request Dr. Lee B. Bell, a senior mind-body specialist in the Department of Hematology Oncology at Columbia University Medical Center, New York, where she has a clinical practice designing mind-body protocol for cancer patient symptoms management at all stages of the care, from diagnosis to the end of the life. Now, may I request Dr. Lee Bell to start your topics.
Thank you very much. Let me pull up my screen for my slides, please. Here. Namaskar, everyone. Thank you to the organizers for the kind invitation to speak. And good morning from New York City, where I am. And hello to all of my Indian colleagues. Good evening to you who are joining tonight.
Good morning.
I am going to talk about yoga and smoking cessation. And the title of my talk is Between the Inhale and Exhale, Role of Yoga in Smoking Cessation for Cancer Risk Reduction. I have no disclosures. And what I want to achieve today, we've got 20 minutes together, so I'm going to try to fit a lot of information in a small time period. But I'm going to discuss the evidence that supports the role of yoga and meditation as a multimodal intervention in smoking cessation programs, and I'm going to recommend their use. And my focus is going to be on this multimodal approach. I'll talk about mindfulness, exercise, breath, stress and anxiety management, and the mechanism of action for yoga. And as we all know, yoga is so much more than just the asana and the exercise. And in the West, so many people think that is yoga, but it goes so much beyond with the mindfulness and the breath. And quitting smoking is a journey, not a single event. And yoga is a lifestyle. So why is this multimodal approach that I'm talking about important for stopping smoking? Well, let's look at 5 points together. So the evidence base shows that substance abuse disorder, and this includes nicotine addiction, it needs a multimodal approach. And this is because there are various domains of symptoms to manage in substance abuse or nicotine addiction, including cognitive, physical, behavioral, psychological. So it makes sense that the treatment must include a variety of interventions to target each of these domains. And the science also tells us that combinations of interventions appear to be more effective than a single approach. So the combination of pharmacotherapy plus these non-pharmacological interventions are more effective than either method alone. And the present evidence base recommends using a combination of these treatments to improve long-term cessation. And we need to remember that no single quit smoking method is effective for all tobacco users. So the ideal program includes a comprehensive variety of evidence-based, evidence-informed, and proven cessation techniques. And so introducing yoga. So yoga is a multidimensional approach to nicotine addiction, and it has broad acceptance. So as I said when I started, yoga includes elements of exercise, meditation, mindfulness, breathwork, and concentration. And it is gaining popularity around the world as a non-pharmaceutical, holistic, integrated approach. And in the United States a few years ago, there was a survey-based study of about 1,800 people in the Midwest, and it showed that a significant percentage of smokers, 27%, were using yoga and meditation already, in addition to or as a replacement for conventional smoking treatments. In addition, 67% of those surveyed, the smokers, who were seeking treatment to quit smoking, said they would be interested in using yoga and meditation to relieve stress and help them to quit smoking. Yoga is acceptable, it is safe, it is cost-effective and scalable. So it is a boon, not only for industrialized nations, but for low middle income countries. So the research on yoga and smoking cessation is just beginning. However, we have robust research on the efficacy of yoga in other populations and for positive mood and positive health promotion. So some of the studied benefits are anxiety, mood disorder, chronic pain, depression, addiction, sleep disturbance, stress, immune imbalances, and a number of musculoskeletal conditions. And so the randomized controlled trials, and this is sort of like the mechanism of yoga, that the practices are acting on the hypothalamic pituitary adrenal axis, and they're reducing cortisol levels in plasma. And a yoga practice also reduces sympathetic nervous system tone and increases vagal activity and elevates the GABA levels in the brain. So I want to start with this first study, and this is the first rigorous randomized clinical trial of yoga as a complementary therapy for smokers attempting to quit. It was published in 2019 in the journal Nicotine and Tobacco Research. And it was conducted at Yale University in the Department of Psychiatry and Human Behavior. And I'm just going to go into a little bit of detail about this because this is an important study. So the participant number, the sample size was 277 people, and 55% of them were women. They were randomized to an 8-week program of cognitive behavioral therapy, smoking cessation, and either Iyengar yoga twice a week or a general wellness class, which was the control. And the assessments included cotinine verified 7-day point prevalence abstinence at week 8, at 3 months, and at 6-month follow-ups. At the baseline, the mean age was 46 years, and the smoking rate was 17 cigarettes or sticks a day. The longitudinally adjusted models for abstinence outcomes demonstrated significant group effects that favored yoga. The yoga participants had a 37% greater odds of achieving abstinence than the wellness participants at the end of treatment, the end of this 8 weeks. The lower baseline smoking rates, less than 10 cigarettes a day, were also associated with a higher likelihood of quitting if given yoga versus wellness classes by the end of the 8 weeks. A significant dose effect was observed for yoga, but not with wellness. And it was such that each yoga class increased quitting odds by the end of the study by 12%. So the conclusion here is that yoga appears to increase the odds of smoking abstinence, and particularly among light smokers. And it does so in a dose response manner. Now, the interesting point about this study I found when I was looking at the discussion, they're talking about mindfulness as a component of yoga. And they hypothesize that mindfulness can be predictive of quitting patterns, and that if they can be identified, this might suggest modifications to therapy for those who are unable to quit. So I found a really exciting study that I want to share with you. So in the United States, the gold standard for quitting smoking is a program developed by the American Lung Association. It's decades old, and they have used it for hundreds of thousands of people to help them quit smoking. It's called Freedom from Smoking. And it's, like I said, it's our gold standard. It's our premier stop smoking program. Now, I found this study that comes out of Yale University, Department of Psychiatry. And it was published in 2016, I think, in the journal Drug and Alcohol Dependence. And it's called Mindfulness Training for Smoking Cessation, results from a randomized controlled trial. And so they're saying that mindfulness training has an excellent track record to show a number of benefits for psychiatric disorders, depression, anxiety, and more recently, addictions. But there's never been a trial to evaluate smoking cessation through RCTs. And so in this study, 88 people who were seeking treatment for stopping smoking, then this was an average of 20 cigarettes a day, were randomized to receive either the mindfulness training or this gold standard from the American Lung Association. And both treatments were delivered twice a week over 4 sessions. So it was 8 sessions total in a group. And the primary outcomes were expired air carbon monoxide, confirmed 7-day point prevalence, abstinence, and number of cigarettes a day at the end of the 4-week treatment, and at follow-up at week 17. And the results are incredible. So 88% of the individuals who received the mindfulness and 84% who received the standard of care with the American Lung Association completed the treatment. So there was really good adherence there. And the individuals who received mindfulness showed a greater rate of reduction in cigarette use during treatment and maintained these gains during follow-up. They also exhibited a trend toward greater point prevalence abstinence rate at the end of treatment, which was significant at the 17-week follow-up. So the conclusion here is that this initial trial of mindfulness, which of course is part of yoga, may confer benefits greater than those associated with the current standard of care for treating smoking cessation in the United States. And I think that is pretty exciting. And I'll say, The American Lung Association program costs $100 to do it online. And if you do it in person, it costs more. So mindfulness is something you can learn and do at home for free. So I'm just quickly going to go through this because I don't want to go over my time, but mindfulness is based on promoting non-judgmental and non-reactive state of awareness that in the long term may improve one's ability to modify automatic behaviors. And trait mindfulness has been adversely associated to severity of nicotine dependence and withdrawal, and positively associated to smoking cessation self-efficacy. And so a consequence of a consistent practice of self-knowledge is an essential factor for decreasing this automatic behavior. And there is association between smoking behavior and impulsivity. And this suggests the reduced reactivity and increased awareness with a mindful practice might counteract the impulsive behavior that often prevents smokers from quitting. Just a little bit about the mechanism of action with regard to the mindfulness. So research on neurobiology of substance abuse disorder shows that chronic drug use and nicotine is associated with deregulated prefrontal dependent cognitive control, which may affect the inhibitory pathways. And neuroimaging data suggests mindfulness practice has the capacity to modify and enhance the mechanism of cognitive control of automatic behaviors, which could help reduce reactivity toward nicotine and, as a consequence, help to stop smoking. I'm moving on now to exercise, and I'm not going to go into these two studies because I know I'm short on time. But there are, again, two important studies published in the journal Nicotine and Tobacco Research around yoga and exercise. This one is acute effects of aerobic exercise and hatha yoga on craving to smoke. And the second one is the acute impact of hatha yoga on craving among smokers attempting to reduce or quit. And we know that exercise reduces tobacco withdrawal and craving, it improves mood, and it helps with weight gain. And most people who try to quit will gain weight, and I think the average is 7 to 10 pounds. So if we look at yoga as a form of exercise through the asana and the vinyasa, it can promote subjective well-being and mood, and it can add to the desire to stop smoking. And as we know, yoga improves cardiopulmonary fitness, flexibility, balance, muscle strength, endurance, and it helps with the mood. Moving to the breath work that I mentioned. So here's a study that talks, it's a randomized controlled trial in the journal Psychopharmacology that talks about the acute effects of yogic breathing exercises on craving and withdrawal symptoms in abstaining smokers. So just quickly, what they found was when they brought the smokers into the laboratory, into clinic, and they gave them a variety of pranayama practices, breathing practices. Immediately afterward, they self-reported decreased levels of craving, and their blood pressure had dropped. Now, unfortunately, this did not happen. It did not sustain itself. It was just acute, right after the practice. But it warrants more research. And we know that breathing, attention to the breath can reduce anxiety, stress, reactivity, and therefore it can be an adjunct treatment for substance abuse. And in the United States, the Public Health Service and smokers themselves cite paying attention to the breath cycle and breathing deeper and fuller as a strategy for coping with the withdrawal symptoms during cessation, attempts for cessation. And then, as we know, the slowing down of the breath affects the parasympathetic nervous system, and it induces a state of relaxation. So it opposes fight or flight and the stimulation of the sympathetic branch of the autonomic nervous system. And stress management is key to smoking cessation. If you look at the reason people smoke, many of them use it to manage stress, distress, anxiety, and negative emotions. And yoga is known to improve the mood and reduce stress. And as I said, another mediational pathway could be the effect of yoga on stress. And in a study,
Excuse me, ma'am, we are running out of time. Please conclude.
Okay, let me conclude. Anyway, yoga is great and everyone should do it. Let me run on this. Let me just finish up with this. So there was a study in India among adolescents and for smoking cessation. And while this wasn't directly about yoga and meditation, it was about how to influence behaviors. The majority of the students, 16 to 18 years old, said that yoga and meditation and the healthy breathing was the most, their most favorite part of this intervention that was given. So more research on the mechanisms. We do have limitations to research, which is sample size and definitions of what is yoga and the dose and the makeup of the participants. So my conclusion is that yoga addresses the barriers to quitting smoking, withdrawal symptoms, anxiety, mood swings, weight gain, difficulty sleeping, anxiousness. The majority of the studies suggest yoga does have potential to aid smoking cessation and reduce substance use, as well as the substance use craving. There is a need for more research. And it's important for all of us as practitioners to have a plan when addressing patients who smoke. Just telling them to quit is not as effective as giving them a plan, a process, and the resources. And we need to understand our patient preference and willingness to make change in order to develop and construct an appropriate program for them. So thank you very much.
Thank you, Dr. Lee, for finishing in time. Thank you very much. It was a pleasure to have you on this platform. I request Dr. Barba to introduce the next speaker, please.
I think the next speaker will be Dr. L. Swasti Sharan. He is the Additional Deputy Director General and Director, Emergency and Medical Relief in the Directorate of Health Services, Ministry of Health and Family Welfare, Government of India. He is also a WHO Fellow in Health Impact Assessment at Liverpool University, United Kingdom. He was also trained in the leadership program in global tobacco control at Johns Hopkins, US, and in the public health leaders program at Emory University, USA. His major areas of interest is the emergency medical relief, pre-hospital care, EM development, life-saving skills, training quality, improvement program, and patient safety issue, and national tobacco control program. May I request Dr. Swasti Sharan to deliver your lectures. Dr. Swasti Sharan.
Thank you so much. Thank you for inviting me here in this important delegations over tobacco use, which is one of those important issues, not just from the health sector, but also from the development point of view. We all know the global burden. We have already had a lot of speakers already speaking about this. It is enough to say here that tobacco really matters, whether it is in the form of smoke form, in the form of cigarettes or biddies or other smokeless tobacco, which is also of predominant importance in the Southeast Asia region, including India being one of the leaders, as well as Bangladesh and Nepal. Therefore, given the burden of the tobacco and the various health effects of tobacco and economic effects of tobacco and the complexity of the tobacco control issues, it had led to the formation of the WHO framework on tobacco control, which in fact is the first public health treaty negotiated under the auspices of the World Health Organization. And We are also positioning ourselves not just in the WHO FCTC, but also at the UN Sustainable Development Goals. We all know, most of us who are working in tobacco, we all know the target 3.4 is to reduce by 2030 one-third premature mortality from NCDs, and one of those target 3A is to strengthen the implementation of what I just said, the WHO Framework Convention on Tobacco Control. WHO, over and above the implementation of the article of the various articles of the WHO FCTC, also comes up with what is known as the Empower strategy. M meaning monitoring tobacco use and prevention, protection, P standing for protection people from tobacco smoke, and O, which is the O component of offering the quitline services, cessation services for tobacco, and W is for warning the dangers of tobacco in terms of the back warnings, etc. And E is enforcing on tobacco advertising, and R for raising the taxes on tobacco. We all know the share of tobacco control policies all across the country. And if you look the component-wise, the M component-wise, we see that the global monitoring built on national monitorings of various countries, which we all have already had many speakers speaking on this area. And the P component, the protect people from tobacco smoke, is the only intervention that has been demonstrated to be fully protecting people from the secondhand smoke. The rights of those people who do not smoke to stay healthy from those active smokers is the primary area of concern, which is over which the P component has been built. The comprehensive smoke-free legislation is in place for almost 1.5 billion people in about 55 countries. So these are some of the examples of the smoke-free law in various countries. And O component, which is to offer quitline, the cessation services, is also in place for about 2.4 billion people in 26 countries. And W comes in different forms in different countries, in different sizes of the back warning, but then it is also there to help us, do away from the use of tobacco, either to initiate or also to encourage to start quitting. E is enforcing bans on tobacco advertising, promotion, and sponsorship. This is one area where the tobacco industry is very, very strongly and actively working. And this is one area where we have to have a bigger or larger population of the world to be covered under this tax ban. Then R, again, is to make tobacco products exorbitantly costly so that people who are, especially those people who are in the marginal population, are not able to buy them in huge amounts, so that the actual consumption of them also dies. So this happens when we raise the taxes on tobacco uniformly on all forms of tobacco. If you do it in the ununiform manner, then the switching of the products from the costly to the less costly also happens. So the policy should be to raise tobacco taxes on all forms of tobacco. I would like to now highlight in the next few minutes about the successful anti-tobacco initiatives that we have done in India. We all know that previous speakers, Dr. Sonu, had also informed us about the Global Adult Tobacco Survey. How many of us in India are also tobacco users? We know that. So currently, as per the 2016-17 GATS-2 survey, 28.6% of India are tobacco users, and the smokers and the smokeless tobacco users are also depicted here. As I said in the beginning, the smokeless tobacco is of concern in the Southeast Asia region, as well as is also in the big concern in India. And the Global Youth Tobacco Survey, we have just released the national fact sheet for the 4th round of the GYTS, where we see that there's a very happy drop of from 14.6 in 2009 to 8.5% in 2019. That is over a decade. We have had this drop of tobacco users, and among the smokers, the drop is not as much compared to what is being shown in the smokeless tobacco. The Empower is being tried in the country in the form of various guidelines. We have a dedicated law, which is known as the Cigarette and Other Tobacco Products Act 2003 in India. And in order to implement this act, we have a program called National Tobacco Control Program. and several guidelines of the ministries are being issued to roll out National Tobacco Control Program with the objectives of enforcing the law which is there, and also increasing awareness about the public regarding regarding the harmful use of tobacco, so that children do not initiate it, and those people who have unfortunately initiated are encouraged to quit through the various facilities available. So mapping the different sections of the Act is Section 4 for the prohibition of smoking in public places, Section 5 for the tabs ban, and 6A and 6B for the prohibition of sale to the minors, and Section 7 is the depiction of specified health warnings leveled on all tobacco product packs, etc. So the tobacco control program, as I say, is rolled out from 2007 onwards, and we have been gradually increasing the coverage of all the districts in the country with these broad objectives, so that we reduce the burden of tobacco and also lead the country to the development of the Sustainable Development Goals, which I have already indicated in the beginning. So Article 5, if you try to map the various articles of the WHO FCTC, Article 5, Article 5.3 is protecting public health policies from the commercial and other vested interests of the tobacco, is well enshrined in the fact that the ministry has issued a guideline, to protect the public health policy from the interests of the tobacco industry. Article 6 is also one area where the price and tax measures to reduce the demand for tobacco is also being done here. The ministry with WHO always commissions a lot of studies. One of them is tobacco taxes in an empirical analysis, and the GST from July 2017 attracts, all tobacco products attracts the highest tax bracket of 28.6. If you go to Article 8, protection from the tobacco smoke exposure, that we have got already the Section 4, and this has been revised again from time to time in order to suit the requirements of the country. Section 9 and 10, which is one of the very important yet very technologically challenging to implement, is being done in India, wherein the ministry has set up 3 labs in India, one in Mumbai, one in Mumbai, another in Guwahati, and another in Noida. So this is what we have done for Article 9 and 10, and we are trying to cater to the needs of Article 9-10 implementation of the entire Southeast Asia region. Article 11, packaging and labeling of tobacco products. We have 85% on both sides of the principal display area of tobacco products. These images also keeps rotating, and we also have the display of the quit line number, so that whoever buys the tobacco product, if one day they decide to try quitting it, they can directly call this quit line number and initiate the process of quitting. The Article 12 is for the education, communication, and training. We have a lot of IEC campaigns done from time to time. We also have many school programs where the Ministry of Health rolls out with the help of the state and the districts. And the various resource materials developed ranges from operational guidelines, law enforcers manual, and other training manuals for the NTCP. Collaborating with other related programs like TB tobacco collaboration, TB diabetes collaboration, and NOHP, the National Oral Health Program, and National Tobacco Control Program integration, etc. And some of these campaigns are very, very popular in India. They are not done by actors, but real patients who have suffered from tobacco-related cancers and who agreed to campaign for anti-tobacco in the country. Many of them are listed here. You can see many of the lady here is Sunita. We dedicate many of the campaigns to her because before her death, she had written to the Prime Minister, to increase the activities of tobacco, anti-tobacco activities in the country. And we also have the boy here. His name is Mukesh. He is also a smokeless tobacco related cancer victim. He had also campaigned for the ministry in the form of many IEC material designed around him. Article 13 is again the tabs ban. We have been working very hard in this area under Section 5, and Article 13, which is for the tobacco advertising, promotion, and sponsorship. we have the film rules, which says that you have to have the anti-tobacco messages at the beginning as well as in the middle, and this comes free to the program. So that's why it is one of the best practices of the country, which has been also studied and copied by many other countries in the world. Then the justification which needs to go, the audiovisual and health warning, prominent static message during the display of tobacco products. These are part of the new films and the tobacco program rules. And there is also prohibition on many of the other things like product placement, etc. And you can see some of these earlier before this rule came out. We had a lot of this happening, but after this, we do not see this in any of our movies or in the point of sale advertisement, etc. The demand reduction measures of Article 14, as I said, is already in the form of tobacco dependence treatment guidelines or the quit line we have created, and the joint tobacco collaborative activities. And the illicit trade in tobacco products, India is also one of those countries which has signed the illicit trade protocol, and hence it works with many ministries which are related with this. And Article 16, the Section 6 of the Code Part of the Tobacco Control Act is related with this, and we have the Tobacco Free Educational Institute guidelines, and every school is being judged as per a scorecard for every institutional educational institution, and we try to reach the 100% score and use that as a proxy indicator. 17-18, we interact with many of the ministries, including Ministry of Agriculture, for alternative livelihood. This again is still a challenge, but we are also working in this area. Article 20, we already have the Global Adult Tobacco Survey, Global Youth Tobacco Survey, and many other economic surveys. Economic studies are also being done commissioned by ministry or WHO or many of the partner organizations. And we also have a special prohibition of electronic cigarettes, the production, manufacture, import, export, transport, sale, distribution, storage, and advertisement Act of 2019, which is a complete comprehensive ban for electronic cigarettes or heated tobacco products or any other form of electronic electronic devices which generate aerosol containing or not containing nicotine at all, but has a mechanism of adding nicotine at all. So that comprehensive ban is there in India by a special act which came out in 2019. The initiatives taken are also being captured by a portal which has got a lot of interesting features to have a real life monitoring of the activities of the program, and we are trying to do whatever we can, but it is really difficult to squeeze all the activities of the National Tobacco Control Program globally as well as in India in a matter of 20 minutes. But this is all I had to share with you. Thank you so much, and thank you for giving me an opportunity.
Thank you, Dr. Swasti Charan. It was very informative, and it was a pleasure having you here on this conference. Thank you very much. With my co-chairperson, Dr. Barwa, I think so now we are at the end of this 7th session, and we thank all the speakers and the coordinators for this session. Thank you, Dr. Abhishek and your team, for inviting us. It was really a pleasure to be here on and chair this session. Thank you very much.
Thank you. Thank you.
Now we hand over the platform to the coordinators again. Harpreet, are you there?
Thank you, sir.
Okay, thank you.
Once again, I would like to thank all the speakers and both the chairpersons for discussing all these illuminating topics. Now I would like to request Dr. Dure Eden to start the next session. Over to you, Dr. Dure.
Thank you, Dr. Harpreet. Good evening, everyone. I'm Dr. Eden, and I would like to thank all the attendees for your patient listening. I would like to introduce our session chairs for the last session of the evening. Dr. P.K. Julka, sir, former professor and head radiation oncology and dean, AIMS, who is currently senior director, Max Cancer Center, Delhi. And Dr. Surekha Kishore ma'am, professor community medicine and executive director, AIMS, Gorakhpur, Uttar Pradesh. And Dr. Sunil Kumar, sir, additional professor, Department of Surgical Oncology, AIMS, Delhi. Now I would like to request Dr. Julga sir to take charge of the session. Over to you, sir.
Ma'am, Dr. P.K. Julka has not joined.
Ma'am, Dr. Sureka Kishore ma'am, is she available?
Yeah, hello. Yeah. Am I audible? Am I audible?
Yes, ma'am, you're audible.
Yeah, I'm there.
Ma'am, you can start the session.
Okay. Okay. So we are going to start the first session, and I have as chairperson with me Dr. Sunil Kumar, who is additional professor, Department of Surgical Oncology, AIMS Delhi. And we begin the first session, and it is being delivered by Dr. Tarun Durga. And the main theme is on engaging tobacco users, motivational interviewing, and brief interventions. So that is a very good topic. I think we are going to have an interesting, discussion later on. So I will request Dr. Tarun Durga, who is a consultant clinical oncologist at Southern University Hospital, NHS Foundation Trust, United Kingdom. So may I request Dr. Tarun Durga to please carry on.
Hi, can you hear me? Hello.
Yeah. Hello.
Can you hear me? Should I start?
Yeah. You are audible, sir. Please.
Okay. So lots of things that I'm going to say in this presentation have been talked by my colleagues earlier in the earlier sessions, but I'll go through the things. Mainly, the thing that I'd be emphasizing the most would be on motivational interview. So just a sec, it's not moving. Sorry, slides are not moving. Yeah, there are no disclosures or conflict of interest. There seems to be a lag phase on the slides. I'm sorry. Yeah. So the talk is going to be divided into two main parts. One is initially briefly about the prevalence effects of tobacco, and then on the smoking and tobacco cessation strategies. Roughly, there are around 267 million tobacco users in India. Approximately 40% of the men above the age of 15, and women are around 15%. In teenagers, the percentage is around 15%, more so amongst boys. Now, looking at the health and economic consequences of smoking, smoking effectively affects all parts of our body. Apart from lung cancer and respiratory diseases, it affects the heart. It also promotes aging and causes vascular events. We do notice quick benefits when we quit smoking. The benefits start appearing within 12 hours of quitting smoking. So actually, we can see the carbon monoxide and other chemical levels start decreasing within 12 hours. The effect on coronary heart disease and vascular events start decreasing within a year, and the effect on lung cancer mortality and lung cancer incidence decreases after around 10 years. Now, tobacco is a big industry. And the reason why most of the places we are failing in some ways managing the effects of tobacco is the economics of it. Roughly around 850 billion market within US only. US Treasury gets around 200 billion, and tobacco advertising within US is around 10 billion. And now the interesting thing which is happening over the developed world, which is likely to take up even in India, is that the global manufacturers of tobacco are slowly shifting to global vapor sales. And they're promoting it as a health product rather than it being a thing that's bad, which is with the smoking. So the industry has slowly grown from around 5 billion to around 20 billion in 2019. And the interesting aspect about it is the profits from this is around 15.2 billion. So that's around 75% of what they use comes back as profits. The other interesting space to watch out is that the tobacco companies are now moving into the inhaler space. Whether it is they're promoting it as a way by which they want to undo the damage of smoking, but my suspicion is that it's more to get better technologies to deposit nicotine and even CBD in more efficient manner in the lungs. Actually, the biggest smoking company which produces Benson engines, cigarettes, etc., Philip Morris actually acquired one company recently in UK, which is mainly an inhaler company. Now, if we look at the tobacco use and smoking trends, globally, the trends are on the falling side, more so in the developed world than in the developing world. This is in India, and this is the global trends within the West. So now, talking about the smoking cessation interventions, there could be pharmaceutical interventions in form of nicotine replacement or combination with other agents like antidepressants. So multiple studies have been done in the last 20 years in US and UK, which have looked at nicotine replacement therapy, venlafaxine therapy, buprenorphine, and combination of nicotine replacement therapies. What has been shown is combination nicotine replacement therapies are more effective than single nicotine replacement therapies. I think the space to watch out is now new studies are being done, although not promoted by the health institutes, is on e-cigarettes, which are trying to promote it more like smoking quitting service. These are not FDA or NICE approved. There was a Cochrane review on nicotine replacement, which looked at 136 trials, and basically the conclusion of that was the chances of smoking cessation is increased by around 50 to 60% by use of nicotine replacement therapies. There are side effects, which include skin effects with these therapies. Equally, a nice article which was published in JAMA showed that combination therapies with nicotine replacement therapies with venlafaxine and nicotine replacement therapy was more efficacious as compared to nicotine replacement therapies on its own. In conclusion, when we combine the two, we are more likely to achieve long-term abstinence, that is 12 weeks or more, and at 6 months with combination therapy rather than single agent. Now, coming down to the e-cigarettes, I just put this one up because actually what's happening with the e-cigarettes is we are using concentrated forms of nicotine, which is being deposited directly in the lungs. And the reason why these are being promoted by the companies is they're saying that it doesn't have any other chemicals apart from nicotine, so the side effects are less likely. Now, the smoking cessation interventions. The commonest ones are behavioral health, which are motivational interviews, behavioral therapies, support groups, yoga, and mindfulness. Now, in motivational interviews is nothing but a good session with your patients, trying to ascertain their needs and addressing those needs. So what is a motivational interview? It's a conversation for change. It is centered around your client. And this is to enhance the person's own motivation and effect a change in the process. This was primarily tried in drug dependence around heroin and around cocaine, but subsequently it was taken up on the smoking. It's a clinically directed consultation which helps you identify, advise, assist, and follow up on cases, and it identifies the precedents associated with smoking. So the basic ethos of a good motivational interview is you should have the right heart set. It has to be a collaboration. with your patient, one has to respect the autonomy of your patient by actually listening to the patient rather than telling them what he or he should not be doing. And one has to be compassionate to the needs of the patient, and they would be specific for each and every individual. Evocation, which is drawing on the person's strengths, that's the patient's strength, and moving and building on it. So the core skills that go in a motivational interview are what is known as ORS. One should begin with an open question. An open question is basically a question saying, how are you? Why did you come? How can I help you? So basically you're giving an opportunity to the patient to talk. This is basically to encourage a long response, and it should not be a question which basically ends up with a yes, no, or a single monosyllable answer. This is a behavioral technique, interviewing, which explores the person's full experience. We continue to affirm during the interview the positives the patient is taking, and it helps the patient to engage with you. One needs to reflect back. You need to basically reinforce on the things that have been told to your patient, told to you by your patient. That is good for your own note taking, and it also helps in building the context and perspective. Periodically summarizing as we go along during the interview helps in establishing the goalposts. Now, with regards to a motivational interview, the important aspect is to engage with your patient. So you have to understand the needs of your patient and talk and not talk over the patient. There has to be mutual agreement about smoking cessation, and it should not be imposed on the patient. What is a bad motivational interview? An interview which starts with closed questions, where the interviewer fixes goalposts without consent, and that leads to conflict, and where the patient and the interview have different agenda. What makes a good interview? The first and foremost is a good setting. It should be a quiet room with no interruptions, mobiles, pagers. One should greet his patient. They should be interested in helping rather than just going through the motions of the interview. Maintaining eye contact is essential to have good communication. Don't be judgmental about what is told to you. Make the interview comfortable to open up. This needs to be a conversation rather than an interrogation. Ideally, one should not take notes during the interview. It should be audio or video recorded. Making notes from recording subsequently helps. Always take verbal consent prior to recording. Video recording helps in self-reflection and assessment for the interviewer himself, because they can do things better as they see what they're doing during the interview. As I mentioned, we always need to start with open questions. Closed questions should only be asked to get specific answers. Try to keep them to as few as possible. If during the interview, you notice that there was some positive change where a patient told you that he cut down from 10 cigarettes to say 8 cigarettes or 5 cigarettes, this may look nothing to you, but for the patient, it was a big step, and one needs to be congratulated on that. The positive attributes that come in the interview where the patient tells you he wants to leave because of his child, family, or his own personal health needs to be built upon, and one needs to reward them by telling them that this can be achieved and this is something one needs to work on. One has to acknowledge the difficulties and problems that a patient would face during the journey for quitting. We have to understand the barriers to quitting, whether they have a friend circle where they smoke a lot, or the wife smokes, or there are other circumstances that are leading to barriers in quitting. It's always better to talk less and listen more during a good interview. My earlier colleague had also talked about this 5A approach, which is basically ask, advise, assess, assist, and arrange. This is the framework of the interview in which we first ask about the current tobacco use, past history, why he or she wants to stop, and any previous attempts at cessation. Subsequently, the interview moves to the next phase where the patient is advised in clear, strong, personalized manner how to quit. The previous attempts at quitting are documented, and then subsequent therapies which would help in assisting the cessation are looked into. The first and foremost is behavioral therapies, which are non-pharmacological. If the patient has already tried these or is not keen to try these, then pharmacological interventions can be looked into. A subsequent follow-up by phone or face-to-face visit always helps in building on the quitting motivation. The pros and cons of motivational interviews, particularly in context of India. Most of the studies and trials on motivational interviews were done in the West, where the resources are infinite. There are significant cultural and attitudinal differences in the practice in the West as compared to India. I have worked in India. Both the patients and the doctors have a prescriptive mode. People want solutions, they don't want to go to the solution. In the West, it's informed choice. And motivational interviews actually are based around informed choice. Whether that informed choice can work in Indian settings is something that needs to be looked into further. The other problem in India is we are made into gods. We are unable to accept personal and skills limitations and therefore don't go on trainings. Equally, for the patients and families, they expect that the professionals should know it all. They would rather want their doctor to do it all for them rather than being sent to a professional for it. The consultants do not have the time or temperament to go through these detailed interviews in the clinic settings in India, given the volume of patients. Now, the solutions to this. We need to identify the smoking cessation service needs within our own setups and how we can resource it. Whether it would be us or trained paramedical or nursing staffs who should be conducting these interviews. We need to audit the outcomes of these interventions and then build upon it. We have to identify what works and what doesn't work. What works in US doesn't necessarily work in India. And in all likelihood, it will not work in India. We need to build on the knowledge base by regular training and research to validate the local interviewing techniques. The methodology that I have talked about is basically validated for the Western audience. Whether it works in India, it's not validated. We need to create a template which can be replicated and personalized as per local needs. Now, the other techniques which are used is behavioral therapy and support groups. Support groups actually play a big role because you can bring along people who manage to quit smoking, and the strategies they adopt to quit smoking can be replicated with the other individuals in the group. Now, looking at the behavioral therapy, there was a Cochrane review in 2017, which showed that there were significant health benefits with cognitive behavior therapy, and there were high rates of smoking cessation when this was offered, and it should be standard of care prior to pharmacological therapies. Now, looking at brief interventions, there's no agreed definition about what is a brief intervention or even the type. The most common accepted attributes of a brief intervention are that it should be limited in number of contacts. It could use a personal or a media channel of communication. the least amount of contact and effort necessary to obtain an impact on health. The common brief interventions which are used are audiovisual messaging. They help in raising the awareness. This can be both positive and negative messaging. Now, as in physiology, we all have learned about conditional reflex. Aversion conditioning, which is this pictorial, is a form of conditioning where we are training our brain to correlate an event with smoking. This is aversion conditioning, which is negative conditioning. There could be positive conditioning as well. And actually, I was looking at the Prime Minister when he was talking to the Olympians who came back, and he was asking them to go to 75 schools to promote about nutrition. That would be positive conditioning. Similar positive conditioning can also be done around smoking cessation. Now, brief interventions. They could be brief messages on the TV, cinema, print media, social media, SMSs, WhatsApp. Our colleagues from Maulana Azad was telling us about automated calls and tele consultations. This is something that we would need to take up on a larger scale in India. The other thing is denying the space to tobacco companies to advertise. Fortunately, direct advertising has more or less vanished, but embedded advertising is still prevalent. This could be in the movies or in the media, or could be in form of sponsorship for cultural, social, and sporting events like Benson Hinge's Cricket World Cup. That was embedded advertising. Now, looking at the future areas of research, this is what is known as the Benso model. This basically looks at, if we look at smoking, we have an intervention on an attempt to quit, which could result in a recent quitting event, or the person could go back to smoking, and the recent quitter may end up becoming a long-term quitter.
Dr. Tarun,
Yeah.
sorry, you are supposed to wind up now. Your time is over.
Okay. I'll just wind up. So, in summary, there is work going around the Benso model, and there is a lot of work which is looked into is what is known as the prospect theory. The summary of that is people hate losses more than they love gains. So we need to build on that, and there needs to be research within India to find our own model of motivational interview. Thank you.
Thank you. Thanks a lot, Dr. Tarun, for a very good information. I think it has opened up eyes towards your interview techniques and motivational interviews for these candidates who are falling in this trap. So it was a good discussion and presentation on this topic. So now, without losing the time, I would like to invite Dr. Joel Fati, who is Associate Teaching Professor in the University of Washington, USA. And he is going to speak on the integration of effective cessation in lung cancer screening. To you, Dr. Joel Fati, and I would request you to please maintain the time. And your timings are for 20 minutes. So please abide by the timings. Dr. Joel?
Yes, thank you.
Dr.
I need
Fati,
to set up my screen. If you'll give me, hello, if you could just give me a moment to get my slide deck up. Can you hear me?
Please. Yeah. You are audible.
Yes, thank you. Hold on. Okay, can you see my slide deck?
No, your slides are not visible.
Okay, one moment. Hold on. Okay, how about now?
Yeah, right. Now it is fine.
Okay, very good.
You can continue.
Okay, great. Thank you. Appreciate it. Okay, good morning or afternoon. Hello, my name is Jawal Fatih, and I want to expressly thank the Indian Society of Clinical Oncology for this invitation to share a few moments with you today. Sorry, just need to get my slide to advance. There we go. We're here today because we share in the Indian Society of Clinical Oncology's mission to protect the public and save lives through disease prevention and cancer control. Today, I'll discuss integration of smoking cessation services into clinical care using current evidence and the U.S. experience in lung cancer screening as an example of the urgency and real-world opportunities to assess proactively and effectively treat tobacco dependence. I have no financial relationships to disclose. It's no secret that diseases related to cigarette smoking lead to the top causes of death globally, with coronary artery disease being the most predominant, followed by stroke, COPD, head and neck, and lung cancers. All these non-communicable diseases are outpacing their incidence 20 years ago and growing in prevalence. We're certainly going in the wrong direction with all these preventable diseases. Tobacco use disorder with cigarette smoking is the most prevalent, is a chronic illness that commonly leads to premature morbidity, disablement, and death if not addressed. While the cigarette smoking rates in India have consistently dropped and are now at an all-time low of 10 to 20% in most states, India has the second largest population of 266 million people who use any tobacco product in the world, with 100 million of those people smoking cigarettes. Half of these people who smoke will die an average of 10 years before their never smoking peers. Of the 100 million people who smoke tobacco products in India, 25% are smoking manufactured tobacco cigarettes. The other 75% are smoking bidis, which are mini cigarette tobacco products made from locally grown coarse tobacco flakes and hand-rolled in Timbrini leaves. Bidis deliver more nicotine, making them more addictive, and have more carbon monoxide and tar that contributes to greater health risks. Bidis date back to the 16th century, are mostly produced and sold by small cottage industries, and entrenched in the Indian culture. This prevalence and uncontrolled manufacturing of bidis make it difficult to regulate these tobacco products and their related diseases, including cancer. Lung cancer is a dominant player in the world as the #1 cancer and cancer killer in men, and #4 for women. Not only is the incidence of lung cancer some of the highest in the world, the mortality rate for those who are diagnosed with lung cancer approaches that of the incidence rate. Bottom line is that people who are diagnosed with lung cancer die of late-stage disease unless it's detected in the setting of lung cancer screening. There are deep societal costs from smoking in India. 805 billion Indian rupees are spent in direct costs for smoking bidis, and another 168 billion Indian rupees spent in indirect costs. But more important, 100 million lives are lost annually from tobacco-related diseases in India. National screening recommendations in the US include screening high-risk individuals who are aged 50 to 80 with at least a 20-pack-year history of smoking cigarettes for lung cancer by low-dose CT scan. Given the opportunity for primary, secondary, and even tertiary prevention and reduction of disease related to cigarette smoke exposure, addressing cigarette smoking is a government mandate for eligible individuals who are undergoing lung cancer screening. Smoking cessation services must be central to all lung cancer screening programs and other clinical encounters for that matter. Using the 2021 United States Preventive Services Task Force screening criteria and eligible population data, an estimated 13.5 million people are at risk, high risk for developing lung cancer, and half of these people are currently smoking cigarettes. This yields a staggering 6.75 million people who could benefit from effective integration of cessation services in their care continuum. This number may be even higher in eligible smokers who don't get screened in other countries with higher prevalence of cigarette smoking like India. There is evidence that addressing smoking in the context of lung cancer screening is impactful. Identification of people who are actively smoking is essential to meaningfully reduce the risk of lung cancer mortality. One of the earliest studies by our esteemed colleagues in the International Early Lung Cancer Action Program studied the impact of lung cancer screening participation on smoking cessation. This research showed that lung cancer screening promotes motivation to quit smoking, with 74% of participants reporting that engaging in lung cancer screening increased their motivation to quit. 23% reported they had quit, and 27% decreased their smoking patterns. To build on these ILCAT findings, there's more recent and significant evidence, both longitudinal regression modeling and systematic reviews, that show just participating in lung cancer screening or having screen-detected abnormalities is correlated with smoking cessation. There's also evidence that helping people who are at high risk for developing lung cancer can benefit from a 3- to 5-fold mortality reduction when they quit smoking and stay quit. A systematic review and meta-analysis examining the effects of smoking cessation after diagnosis of a primary lung tumor shows that quitting smoking controls lung cancer and smoking-related comorbidities, with at least a 30% increased 5-year survival for people with early-stage lung cancer who quit smoking over those who don't. Nearly 80% of people who are at high risk for lung cancer report they've tried to quit. This is much higher than the 50% in the general US population who make a quit attempt on their own. However, 60% of these people report low levels of confidence that they can quit. Provision of combination behavioral and pharmacotherapy yields the best cessation outcomes, delivering a 70 to 100% increased chance of successful smoking cessation compared to either intervention alone. This evidence is the premise for the Grade A tobacco smoking cessation in adults recommendation by the United States Preventive Services Task Force that all adults are asked about tobacco use, advised to quit using tobacco, and provided behavioral interventions and US Federal Drug Administration approved pharmacotherapy for cessation. Despite the national recommendations and current evidence that clearly shows the benefits of evidence-based interventions for cessation success, people still aren't getting what they need. More than half of people who smoke are given advice to quit, yet nearly 70% are not provided evidence-based cessation treatment. 29% receive a prescription for medication treatment, but only 6.8% receive cessation counseling, and even less receive the evidence-based gold standard combination therapy. The International Lung Cancer Consortium studies show that we should never give up on people who smoke with lung cancer. We should keep trying to help them quit and help them stay quit, because the longer they are quit, the better chances they have at surviving lung cancer. So we know volumes of people who smoke and are at risk for lung cancer are interested in quitting. And we know that quitting, no matter where someone is on the care continuum, have much to gain from quitting smoking. So why don't more people quit? Nicotine is notable for its potent and addictive properties in cigarettes and other tobacco products, commanding strong physical dependence and complex behavioral conditioning that lead to habitual activities and chronic relapsing substance use disorder. Tobacco cessation is a process and may take an average of 30 quit attempts to succeed. Knowing this, healthcare professionals must be poised and prepared to routinely screen patients for tobacco use, including cigarette smoking, with all healthcare touchpoints, and provide ongoing treatment, counseling, and referral for related services. As we focus our attention on addressing tobacco use across the cancer continuum and beyond, it's crucial that we address the destructive and alienating stigmatized perceptions, attitudes, and actions that lead to shaming and blaming people for smoking. We must avoid compromised messaging and communication or withholding care that lead to self-stigmatization, delayed care, and poor health outcomes for people who have a history of smoking. We must also demonstrate non-judgmental and compassionate attitudes and empathic communication when connecting with people who may be at risk for lung cancer and other tobacco-related diseases. The body of evidence that informs us on how to approach integration of smoking cessation services into lung cancer screening is growing. A recent study examined factors that are contributors to lung cancer screening participants dropping out of smoking cessation trials. These researchers discovered significant correlation with dropping out of smoking cessation engagement when they're less worried about their lung cancer screening results and when they have negative lung cancer screening results. They also found higher dropout rates amongst first-time lung cancer screening goers versus those in follow-up for subsequent films. These findings call for actionable strategies to address these barriers to care in high-risk people, including knowledge deficits for patients and providers. An interesting survey sampled 93 lung cancer screening site coordinators to examine organizational priorities, current practice patterns, and barriers for delivery of evidence-based tobacco use treatment across the lung cancer screening sites. The results of the survey illuminated several key areas for consideration when developing a lung cancer screening program. This study showed that people were routinely advised to quit smoking, but cessation medications were recommended only 36% of the time, and participants were less interested in cessation advice and treatment on follow-up screens. This evidence drives the urgency for building a full complement of smoking cessation services, including proactively providing access to FDA-approved cessation medications and treatment guidance into our lung cancer screening and other clinical programs. This study also identified institutional and provider barriers in the provision of smoking cessation treatment, including perceptions that patients lacked motivation to quit and were resistant to cessation advice and treatment, a lack of institutional support for tobacco treatment, a lack of tobacco treatment champions or identified designated providers of cessation services, a lack of confidence in how to help patients quit smoking, lack of time in screening visit to address smoking, and lack of familiarity with tobacco treatment practice guidelines. Understanding that social position and power shape human identities and access to resources is critical, particularly when working with people who suffer from tobacco use disorder. Our personal values, views, and location influence how we understand the world. Understanding and acknowledging our positionality allows us to recognize and respond to complex power dynamics with our patients. Thoughtfully constructing healthcare systems to support vulnerable individuals who use tobacco and entering every patient relationship with an awareness of our own positionality and privilege is critical to the success of patient-centered care and clinical outcomes. Similar to all clinical settings, there are varied clinical care delivery pathways depending on the type of lung cancer screening program, how it's resourced and staffed. The variation in screening program design may also be complicated by variation in health systems and community resources. This calls for innovation and collaboration when integrating cessation services into any clinical care delivery model, including lung cancer screening. We're talking about addressing tobacco cessation in the context of lung cancer screening today, but most know that tobacco use disorder should be thoughtfully and meaningfully included in all clinical encounters and universally and consistently addressed no matter where people are on the care continuum. This care should include access to smoking cessation services with individualized risk and harm reduction assessments. It is essential that coordinated care planning and comprehensive services that meet the patient's addiction, mental health, and primary care needs are provided when necessary, with one-on-one support and follow-up. Furthermore, quality tracking and outcome measures for patient panel and population management are essential to shorten long-term success. Identification and development of available resources and staffing models are critical to consider when executing a plan for integration of cessation services in clinical care. This diagram shows a myriad of potential resources for partnership in dissemination of cessation services. Our commitment to evidence-based practice and innovation in personalized care delivery models and reaching patients holds the greatest potential of changing and saving lives, particularly for those who are most vulnerable. Certain vulnerable populations and minority groups suffered disproportionate rates of tobacco dependence and morbidity and mortality related to their tobacco use disorder and nicotine dependence, including lung cancer. On the heels of the global pandemic and public health emergency, using technology to reach patients by telehealth to extend clinician services through access expansion, cost reductions, and improvement in the quality of care is now feasible and should be a standard of care. There are many considerations when determining the best approach to helping people quit smoking. Effective integration and implementation of cessation services in the care continuum should be flexible and provide options for patients and their family members and caregivers that embraces them in partnership in their healthcare decisions. This includes thoughtful designs of clinical care delivery models that provide a myriad of care modalities that meet their needs. The National Cancer Institute is currently funding large studies and initiatives across nearly 30 institutions to research and determine the most effective interventions and implementation strategies of smoking cessation treatment in the context of lung cancer screening and cancer care. Publication of the results from the Cancer Center, cessation initiatives, and smoking cessation within the context of lung cancer screening are eagerly anticipated to help inform all of us on best practices in integrating smoking cessation across the cancer continuum, including lung cancer screening. Bringing the evidence forward that we've discussed today is critical in making the argument that we need to integrate smoking cessation services in our screening programs and perhaps even beyond the screening environment. A pragmatic approach in this effort needs to be grounded in core relationships and is initiated through outreach and relationship building at high level in the institution, working from the top down. It includes identifying institutional champions, addressing health system and facility design to promote cessation services, leveraging the electronic health record for cessation services, and sincere investment in provider development and patient education. Finally, it's critical that we continue to advance implementation research and initiatives, examine the design of health systems and clinical workflows, and identify and develop the healthcare workforce to provide evidence-based cessation services at the right time for patients. Thank you for your time today. Sorry, we can't hear you. I think you're muted. Dr.
Ma'am, you need to
Kishore, you're
unmute yourself.
muted.
Okay, right. Am I audible now? Hello.
Yes, you are.
Yeah, am I audible? Right. Okay, thank you, Dr. Jolie Fethi. And you have really given a very good presentation, and it was very informative to all of us. Thanks a lot. And you had kept the timings also, so thanks a lot for that. And now I would like to invite Dr. Abhishek Shankar, who is Assistant Professor in the Department of Radiation Oncology in Lady Hardinge Medical College, Delhi, India. And before I call him upon, I would just like to mention that he had been my student, and he is very hardworking and very sincere doctor, and I wish him all the best for this presentation. He is going to speak on marketing determinants of anti-tobacco campaign. So I would like to invite Dr. Abhishek Shankar. Dr. Abhishek, over to you. Dr. Abhishek?
Am I audible, ma'am?
Yeah, right.
Yeah, let me, Ravinder, please allow me to share my screen because it's telling host disable participant screen sharing. Yes, I can do that.
Yeah, it's okay now. Yeah, visible.
Yes. So thank you so much, Chairperson, for this nice introduction. And thank you, Jolie, for this excellent presentation. So generally, the chair starts the conference. And in contrary to this fact, I'm just closing the conference. So I'm the last person because it's a very unusual topic. People doesn't, talk about this marketing determinants of anti-tobacco campaign, because now I have understood, I have joined, master in business administration. Then, I used to think that sales and marketing are the same. So now I've understood that sales is just like earning profit and marketing is just like customer satisfaction. So probably this is a very important learning for me, how to satisfy my customer and my patient. And probably that approach is very much relevant in every part of, our working, where it's a tobacco control, where it's a cancer treatment. So this is, thank you everyone for making it possible. And I will request everyone, except for the World Tobacco Day, where everybody is so active, which is celebrated on 31st May, everybody has to remember it. People should take all this activity apart from that, so that we can reach to more number of people and more number of people can be educated. So I have nothing to disclose for this presentation, but I just want to inform everybody that tobacco products kill more than 8 million people every year. So now you can understand, we are just making hue and cry for the COVID-19, but still more people are dying because of tobacco use in the globally. So what kind of attention is given to the COVID-19? It is an important disease where we all have to give our time, management skill, but tobacco is also important. Apart from in the post-COVID world, I will expect the same kind of temperament and the campaign for the tobacco. So this is a very important article published in Lancet Global Health, where WHO Director General Margaret Chan in 2016 said that efforts to prevent non-communicable disease go against the business interest of powerful economic operators. So what can be better understanding for the tobacco industries, where tobacco is one of the major killer for NCD and cancer. Being a cancer specialist, I can understand that in India, 27% of the cancers are attributed to this tobacco use. So high prevalence, why it is important to talk about marketing aspects of anti-tobacco campaign, because there's a high prevalence of tobacco use in India. Almost 29% youth use tobacco in one or the other form. Young people are more likely to adopt this habit. Tobacco use has socio-economic and demographic variables, and in India we can understand, wherever we go, we see their habits, we can understand. So tobacco companies spend so much on marketing to reach the potential customers, but in contrary to that, doctors, policymakers, government are not having the same approach to counter them. So we are missing the marketing approach in anti-tobacco efforts. So formulation of demarketing strategies are existing right now, but we need to be more attacking as far as marketing approaches are concerned. This is an eye-opener. So market will accelerate in giving a annual growth rate closing to 4% to the tobacco industry, and it is reaching to the 167.84 billion. So it is just less than the the year growth rate for the 2019 is 3.57%. So this market is highly fragmented with few players ruling the game. You can see in India also. If I ask anybody which one is the major cigarette producer, everybody will say it's ITC. If I will ask the second one, people will take time to remember. So 49, and the bad part for the Asian or Asia Pacific region is that 49% of the tobacco market growth will come from Asian Pacific region. So one of the key drivers for this market will be the rising demands for cigars and smoking tobacco products. So this is what we do in a smoker's life cycle. So probably a pre-consumption mode, when I'm not aware my smoking is a problem, many of the people you will encounter, and they have no intention to quit, and the changing to the consumption level, when I know my smoking is a problem, I want to quit, but I don't have plan A. To prepare, because somebody has cough, during this time, and having a chronic history, they start preparing themselves. So, okay, I'm planning to quit and I'm changing thing. I am in preparatory mode to the action mode. When something, they become more severe symptoms like cough, which is chronic, and somebody scares them like doctor like me. So they plan it and they just do it. So this is called action. So many of the people I have seen, they quit smoking for 2 years, 3 years, and again, for a small stimulus, which again put them in a smoking pattern. So that is very, very difficult to maintain the maintenance, and people fall in relapse, then the same cycle starts once again. So this is historically, and I think cancer continuum doesn't give importance to the anti-suggestion, anti-smoking suggestion activity, because being a doctor, we always ask, your smoke frequency, intensity is a part of importance for us. But after that, we just don't advise what are the suggestion methods, how to do. And, it's very surprise, it's very to say that many of the cancer centers are not having the suggestion services, as a part of the continuum of care, which we have to make it. So these are the marketing channels, the drivers, and the channels, marketing, supply chain, lobbying for cigarette and tobacco, other tobacco products. You see that their marketing is very intense. They are very attacking, and lobbying, you can see them in the, political arena. They are lobbying for this, giving some or the other examples. Sometimes they talk about the farmer rights, and for the outcome, you should have environment, consumers, and health is most important aspects, which COVID-19 has made us, alerted, but still tobacco is growing day by day. So this is called logic model. Probably it has some logical. So cigarette company, or tobacco companies, they pay for the ads, then they design the industry manipulation ad, then output as industry manipulation ad is aired on the stations and the time to reach youth, because youth is the target. So they have the short-term outcome, intermediate outcome, and the long-term outcome associated with that. So this is one article I found from the India, which talked about, demarketing strategy, which right now government of India is doing. We discourage the users to reduce smoking, increase taxation by doing, increase on taxation by banning on the sales. We have the Kotpa rule in place, because that, the cigarette and other tobacco product acts, which talks about, where you have to sell the tobacco products, you have to just a few meters away from the institution, you can't advertise it, there is a ban on the advertisement. But many of the times you see, because many of the have adopted the alternative marketing strategy, because some company is making beer and they're advertising the mineral water. So what, it's in psychology. Whenever you see Kingfisher, you'd never think about the drinking water. You always think, although advertising it for the drinking water, but suddenly what clicks on your mind is the beer. So it is one point of which is the, divergent strategy for the marketing. And but still, in spite of all the efforts by the Kotpa and the framework, one of the framework was happened in India a few years back. So impact is debatable, and still we are able to and not able to convince and make the ground level, changes at present. So this is the main, anti-tobacco campaign marketing aspects. So describe the problem, identify how counter marketing approaches can address it. We need to identify and learn about target audience. We need to draft counter marketing objectives. We need to determine and counter marketing measures, approaches, pathway, and program strategy, which is a very important component. Then we need to consider collaboration, because this is a society-based approach, community-based approach. Without collaboration, it is very difficult to deliver and fulfill the primary and the secondary endpoints. So we need to plan for process and outcome evaluation. And then if all this thing satisfies, then we need to start with a counter marketing program development. So I will go one by one. The first one, we need to have the specific outcome, multiple target audience, multiple tactics, because we don't know what will work on what kind of population. So these are the strategy, which we can reach to the people. So we need to have tailored messages, formatting, research, consistency, commitment over time. This all thing is needed, as a marketing determinant to reach to the people and make an impact on the longer period of time. So target audience, this is what target audience. There are many theories which works at the individual level, interpersonal level, and community scale level. So change model, because everybody wants to change. If you're a smoker, you always readiness to change or attempt to change. This is called, change model. Health belief model, because you have a perception that yes, it is a threat to my health, so I might, quit smoking. Consumer information model, where consumers acquire and use information and marketing decision. Then social learning theory. This is behavior explained by a three-way dynamic reciprocal theory, which targets the personal factors, environmental factors, and the behavior. Then coming to the community level, which is very important to change to have a bigger impact in the tobacco cessation, area. So community organization theory, active community participation and development of community that can better evaluate and solve health and social problem. Organizational change, because processes and strategies for increasing the changes that healthy policies and programs will be adopted. Then come the diffusion of innovation theory, have few new ideas, product, and social practices spread within a society from one society to other. This is, published very beautifully in the National Cancer Institute, USA in 1995. Then I have taken, that content from there. So coming to the draft, so it should be a specific campaign, it should be measurable. Sometimes we are very, very, over enthusiastic, and we can make a plan which is never possible and feasible on the ground. So it should be as much as easily achievable. So it should have a relevant, and the most important, it should have a time bound. And that there is a problem, because all the community based approaches, if you want to fulfill your primary endpoint and the short term goal, it takes years and years, and nobody is ready to spend that time. Everybody wants things to occur in quick succession, which is not possible for the community based approaches. So approaches pathway, we need to work on advertisement, public relations, grassroots marketing is the main thing, because most of the company, like you see Amazon, you see Mantra, they are reaching to the grassroots, but we need that approach to cover the grassroots people where tobacco consumption is really a problem. We need to understand the media advocacy, how we use the media for our advocacy campaign, and the most important, we need to make our media literate, otherwise it will lead to disaster. They are unable to report, and it's sensible and the sincere reporting as far as the anti-tobacco efforts are concerned. So collaboration, which is we need to decide whether to whom to collaborate with an organization with a similar goal, with the criteria for the partnership participation. So we need to make partners with a common goal. So plan for process evaluation. We need to evaluation. In the most of the time, we never evaluate our efforts. We always think whatever we are going to do and whatever we'll do will create a magic, which we have to evaluate in between our process and outcome, whatever we have, get at the end of the study or the implementation, so that we can share with others, so that it can be a successful model and it can be implemented in the same geographical area with the same socio-cultural determinants. So counter marketing we have to make, and I would like to give the example of California, where they started counter marketing tobacco, anti-tobacco campaign. There's a media element was there, main messages, dangers of tobacco use and secondhand smoke, industry manipulation, target audience include ethnically diverse communities. So polio is a big example. India has achieved success, and we can say that India has eradicated polio. So what was important, how the same approach can help us in getting something better. So made advocacy effective, written message simple and impactful, keep the visual messages interesting, target the audience, which should be the target audience, share something new. So I will give the countermeasures what we are doing right now in the country. So create the demand, organize did you know campaigns, public recognition to ambassador. It is very important to have the ambassador for anti-tobacco activity. And we are very unfortunate that once time Rahul Dravid was the ambassador for anti-tobacco activity for the government of India, but we could not see much action. But we have many brand ambassador who is promoting tobacco. I will come in the next slide. So we need to engage the celebrity, and many celebrity have lost their parents, close family members due to the tobacco. So either we can engage them, or we can engage the celebrity who is a tobacco victim, and that will be the best example to influence others. Tobacco awareness campaign is the need of time. So media opportunity, they need to designing health communication campaigns. They need to message for combating rumors, which is very important, because in every part of, at least in our country, nobody can give you anything except advice. So you need to check it. And for like now people have started, getting the right information, start by checking the WHO ICMR site as far as COVID is concerned. So multiple channels for communication should open, inviting people to narrate their stories, plan promotion of anti-tobacco messages. So health promotion training and guideline is a very important, and India has a dedicated program which Swasti Charan sir has already talked about, National Tobacco Control Program. So training is going on, communication and social mobilization. There is, much need to do it. Mentorship and fellowship needs to be, added to that. There's a motivation of health workers and volunteers and a student, so they can work on ground. And involvement of NGO is very important to make things happen at ground. So better truth of anti-tobacco efforts. I'm so sorry if I have hurt anybody. So make advocacy effective. If I have talked to the right masses, first message you can see there is a skull and there's a cigarette. How dangerous it is, in our movie theater. We used to go and there is an ad going on. It was so, ugly. It was so, many of the times people used to avoid going to and, early reaching to the movie theater to avoid ad. The second ad, I saw somewhere that it leads to importance. This kind of direct messages will never help people to, make an advocacy effective. This is a UICC. They have clear-cut said with the beautiful lines that yes, 25% of the world population are, having tobacco users. Choose life, not tobacco. This is, this is very simple, but, you should have a effective and meaningful, messages to give to the others. Create demand. I talked about using the brand ambassador, but in India, brand ambassador are used to promote the, tobacco, because in one of the ad published in the Times of India on the front page, where the 007 was advertising pan masala, which is, I don't understand. And now with the new gutka, so many of the Bollywood stars, which is the role model for the many people, have come across and they are just doing. So we need to just reverse it. We have to counter this by making a good marketing strategy and hiring the people who are just countering their side effects. So media opportunity we give them, and many of the times it happens that media shows one program of half an hour for the tobacco, especially on the 31st May. They used to follow you for your bites and the important information, because for them, celebrating, anti-tobacco day is important. Rest of the 364 days, people are not using tobacco. So media opportunity, they are just advertising, and rest, if you keep on advertising the other, tobacco advertisement, so it is very difficult to make a balance. So ultimately, some good things is there. Government is doing anti-tobacco activities for many years. They are running the promotion, training, guidelines. So we have reached to a level, but I have said, this is not enough. So we need to work hard on that, and we have to work together. That is the one thing which we have to make sure. So one thing that first day, Dr. P.C. Gupta has said that LIC, do you know that highest investment in LIC is by the ITC, which is called Indian Tobacco Company, which is against the government in, a standard. No company can invest more than 15%, in the other company as their investment, but ITC, LIC share is 16.29% as indicated in March 31, 2017. So then only I used to decode the, punchline of LIC, that Jindagi ke saath bhi, Jindagi ke baad bhi. That means you're smoking cigarettes, then also, the money is going to LIC. If you die also, the LIC is the beneficiary. So we need to just take care of this thing. So what is important as an oncologist, this is what we see in our day-to-day life. And this is very painful to see. Then, this is, having a negative effect over from a mindset, but people talk about the good part of the tobacco. The farmer will have no job to play. But, think about this, the people who are suffering, and the many family has been ruined, not because the other factor, it's because of the one single factor, which is, killing many, many of the people in India and across the world. So we need to do something about it. So from this point to remember is effective planning will help us better understand the tobacco control issue we are addressing, identify the most appropriate approach to bring out our support chain, create a counter marketing program that support clearly defined objective. So your counter marketing program plan should complement the broader tobacco control efforts and overall plan. So I will request everyone, if you want to know more, there is a document by CDC which talks about designing and implementing an effective tobacco counter marketing campaign. You can read it. So to end, we is the okay, so we have to work together, because illness starts with I. So I don't want to use the I concept, which makes you ill. So we want to believe in wellness, which is start with we. So we need to be hopeful, because healthy communities have hope, and those with hope have everything. Thank you so much once again for your patience hearing. If you have any question, I will be very happy to answer. Thank you so much.
Thank you, Dr. Abhishek. If any of the participant has got any query or question to Dr. Abhishek and other speakers, they can put up the questions. Okay, thank you once again, Dr. Abhishek, for a
Thank you,
beautiful and
ma'am.
excellent presentation. And you have very nicely detailed out all the intricate and minute details and issues related to this campaign for tuberculosis control and the role of marketing, which is a very important issue, which probably, we either ignore or, we just overlook. So I think very
I
nicely
will
you have covered
request
all the
Sunil
points.
Kumar sir to, if he wants to say something, your
Yeah,
co-chair,
sure.
Sunil Kumar sir.
I think let ma'am speak. She was saying something. So
Yeah.
No, that's fine. I have covered, sir. And please, I didn't know whether you were there or not. I think one
I was
of
there
our
also. Don't worry. Yeah.
chairperson was not there, so I thought probably you are also not amidst us. So please, sir, please.
No, I think Dr. Abhishek has covered very nicely, and more important was the last slide, that I stands for isolation and V stands for wellness. That is true. Important is that unless there is a counter campaign regarding the very nexus also of what is the anti-tobacco research being funded by Godfrey Phillips and companies like that, then only the real picture will be coming up. Because what looks on top of that might not be the actual one. So Abhishek, if you have some comments about that, just let us enlighten.
Yes, sir. We need to, plan the anti-research activity, and, funding is not a problem, but, and always I think supply side, there is no problem. There are always from the demand side. If you ask about tobacco cessation, we are ready to, advise somebody, you are ready, you are dealing with lung cancer. But, sir, demand side, there is a problem. Nobody wants to come to you, and if they think that you're going to counsel them, they will run away from you. So we need to create the demand, and to create the demand, we need to work hard. We need to see that what all intervention, and one is the time, because we need to devote more time to increase the demand, to make people understand this is a very important, because many of the speakers I was hearing had clear-cut said that in a cancer patient, if you quit tobacco during your treatment, it is beneficial and it is important for the survival benefit, which we have to advocate, and we have to just, throw more light on that, and we need to discuss it more often, because, and as I said, this kind of program and is more thing, and Dr. Reddy said that how important it is to address because we have the high volume of tobacco users, but we are low resource country. So how we have to close the gap. So I strongly agree with you, sir. We need to, we need to some focus and some component of tobacco cessation in every research we do on the, tobacco associated cancer.
I wish Dr. Rajkumar was here to speak about how to.
Yes, sir. Public health approach.
Tobacco cessation clinic.
Yeah, because he missed it because he was traveling and there is heavy rain. So
that is something we would have really appreciated if something is there to really implement is on ground level.
Yeah, because
we have different ideas about that, but if we have a even preliminary form of a tobacco cessation clinic associated with almost every medical college also. Now,
yes,
I am not sure how many medical colleges are actually having that.
Sir, it is very difficult to answer because whatever medical colleges I have seen, I haven't found it. So.
Exactly. So unless we have that preliminary experience also, then probably we'll in a much better position to answer the question that how much is the demand actually.
Yes. So Tarun Durga sir has raised.
So basically, I just wanted to highlight that actually, even in UK, sending people to tobacco cessation is not easy. It's quite a difficult thing, and only the very motivated go. But one thing which is clearly seen is during the initial consultation when you're doing about treatments, if around that time you're talking about tobacco and the effects it's going to have on the outcomes, people listen to you. They may not go in for formal cessation services, but it does have an impact. equally what I have noticed, particularly in India, is people have started talking about genetic counseling and loads of other things which would need more tests. But very little effort is being done to basically just record how much is the smoking years and what impact it had. So if we look at our clinical notes, that includes private hospitals, not much is going into documenting the smoking intake. And that's something to be looked at.
Sunil sir, I will request Rajkumar sir to share the presentation so that I can share it with all. So that because you rightly said it was very important, and that's what I because sir is the national center authorized by Government of India for quitline, so he has real work experience. So I will request sir.
That's why I was really anticipating his lecture, particularly that I mean, it's easy to talk about so many aspects of the tobacco cessation as such, but unless we have a good framework and even a simplest form of a ground level implementable kind of solution, then only you will come to know that. Why I'm asking is that almost all the patients who are like suffering from cancer or so, forget about them. Obviously, they have seen the bad effect and all that. But those who have been visiting essentially any cancer hospital or so, they are much more kind of sensitive and receptive to the very idea about that. Let's start with only those relatives or the attendants or so. Even that will give a good number, and I can tell you that once the word starts spreading, definitely it gets momentum, and then the clinic itself will get so busy that obviously there is a lot of work to be done.
Yes, sir.
Fine.
If there is no
We had a
question,
fantastic session, and now I'd like to hand it over to the coordinators again. Thanks. Almost all the speakers, they were brilliant in the sense that the very intricacies of their topics was brought to the fore. Again, I missed Dr. Rajkumar's anticipated lecture. Thank you very much.
Thank you, chairpersons, for conducting this session so well. And thank you, audience, for being so patient listener. Now, as we move ahead to end this symposium, I would like to invite Dr. Deepak for the closing remark. Over to you, Dr. Deepak.
Thank you, Dr. Eden. It has been a great day. In last 2 days, we have discussed, shared, and learned about tobacco control and smoking sessions. First, I would like to congratulate all of you on such a successful event and such fruitful discussion. And thank to all the faculty members and participants to join the International Conference on Tobacco Control and Smoking Cessation. There have been many interesting and useful presentations, inaugural, preliminary, and other sessions. I believe many good experiences have been shared and good lessons learned. We have discussed the role of organizations like UICC in tobacco sessions, willpower and tobacco addiction, sociocultural determinants of tobacco use, molecular and inflammatory changes due to tobacco use, economic burden of tobacco use, psychological and behavioral intervention, and approach to patient for tobacco sessions, community-based tobacco session, and marketing determinants of anti-tobacco campaigns, and many other topics. We all know that much important work remains to be done. We need to address the cancer and other diseases risk associated with tobacco. We need to aware the public about harmful effect of tobacco, and media can play an important role in disseminating such messages. I would like to thank the chief guest, special guest, and all the chairpersons and speakers. All of you have contributed to making the discussion so rich and to make conference such a success. I sincerely hope together our effort can reduce the burden of tobacco-related diseases. I would also like to take this opportunity to thank our sponsors, Ministry of Health and Family Welfare, Government of India, GAIL India, Footwear Design and Development Institute, Noida, India, Roche and Zydus. I also thank our supporters, Asian Pacific Journal of Cancer Prevention, Asian Pacific Organization of Cancer Prevention, Asian Pacific Journal of Cancer Care, Society of Cardiovascular Health and Medbound, and Department of Radiation Oncology, Lady Hardinge Medical College and associated hospitals for jointly organizing this conference. Finally, I would like to thank all the members of our organizing team to ensuring smoothly proceeding of the conference. Dear all, You have participated actively, and I'm sure you all are looking forward to enjoy the weekend. So thank you once again, and thank you for your participation, and have a good day. Thank you.